I wish you all robust internet access for the next few hours as we try to come together and meet each other and hear a little bit about the exciting work that's being done in the Cancer Prevention and Control Program, with a particular focus on a couple of areas where the Cancer Center has decided to focus on in terms of cross-cutting themes, particularly in two areas of metabolism and cancer, emphasizing that the word metabolism is very, very, very broadly defined, and also the area where we have some notable expertise in terms of aging and cancer. We'll also pepper in a few other presentations of other research going on at within the CPC program, including I'll give you a little bit of an overview or state of the Cancer Prevention Control Program that will leverage the EAB slides that Raj and I used when we presented in 2 decades ago, I think by now, in was February or March, I believe, was our EAB meeting, and then a few other presentations by folks in our illustrious group. So I think you probably all know where the restrooms are, so we don't need to cover that for this meeting. If you don't, I have other concerns. But we'll go ahead and jump in, and I want to turn things over right now to Kathy, who is all obviously well known to everyone, for some comments about the program. And Kathy, I'll stop sharing and allow you to take the screen.
Sounds good. Thank you, Jamie. Well, welcome everyone to our first, and I hope our very last virtual CPC retreat. It would be nice to not have to keep doing this, but I really thank you guys for participating and coming. And this is such a terrific program, and it's such an honor to be part of it and to continue to see it grow and mature. So what I'm going to do is show you a couple slides about sort of where we are, where we're going, and also to ground you into where we've been relative to our last renewal in 2016. I want to answer your questions, but I also want to keep everything on time. So what I'd like you to do is any questions you have for me, just put in the chat, and I'll respond to it as we're going forward. And that way I won't get Jamie behind from the very, very beginning. So let me share my screen, and hopefully I'll have the right screen. Okay. All right. So everybody knows who I am. And let's see if we can get it to advance. Okay. So some leadership announcements. First, that Jamie Stutz has taken over as a program co-leader. Stacy Fisher will be joining the leadership team of Cancer Prevention and Control, and I can't be happier. So Stacy, thank you so much. And I really look forward to your leadership and the overall leadership team. So fantastic. Evelyn Borreo, she has been a member of our program from CSU, but now she is our Associate Director for Community Outreach and Engagement and has built an entire CEO team that we can all be so proud of. And she's here to facilitate our research into the community and do the really important translation work, and also to bring the community needs to us. So it's a two-way street, and I'm sure she's going to tell you a whole lot more about it. Population Health Shared Resource, a resource that did not exist for our program in 2016. We have new leadership there as well. Marcela Pereon joins Jamie as the co-leader, and Elizabeth Meyer is the manager of that group. And we are currently recruiting for a new Associate Director of Population Health Sciences, which is the role that I have held and still hold in an interim basis, but will be transitioning completely out of it as I do more of the deputy director type of things. So we'll be bringing in another CPC leader, and I expect that person to start in July of 2021. And we have a great candidate pool so far, so it's been terrific. A few program highlights. Russ Glasgow received a P50 in dissemination and implementation. He's going to be telling you a ton about that. Betsy Risendahl, the Colorado Cancer Patient Navigation Program, was awarded. Paul McLean, the Obesity and Nutrition Center. There have been multiple PI awards, such that if I listed them all, I would run over Jamie's allotted time. You awards as well. And we have strengthened research and disparities, HPV, tobacco addiction, and data modeling. So some huge accomplishments. What are we all worried about? The CCSG, it's due. We have our EAB coming up in November. And as you know, the CCSG is our Cancer Center core grant. Our competing renewal gets submitted in January. Our site visit is then in May or June, and it's really important to be very nice to Jamie during this time because he is pulling all of the data together and trying to showcase everything that we're doing. So he may be asking for something and feel really panicked and rushed only because he is. He's not exaggerating that level of effort that requires us to go in for this renewal. It is just a huge project to get it all done. And so that's what our leadership team is really focused on. So how do we feel about going into this renewal? I personally feel fantastic about it. Our metrics, we now have 58 members, so 15 of which are mentored members and growing. We're the smallest program. The Cancer Center has 4 programs. We're the smallest. However, we have one of the most publications. Since our renewal, our team, you guys have produced 604 publications. However, about a third of those have been in the last year. So you can really see our trajectory in the upward direction. 34% of them are collaborative, 29% are written with people from other NCI centers. So we have a lot to be proud of. We're definitely a team that is playing on the national front and shaping cancer prevention and control. So in 2020, we have about almost $6 million in direct grant dollars. In 2016, in our last renewal, we were much lower, and the balance of that money was mostly in non-peer review funding, which the NCI no longer really allows us to count. So if you look at our NCI portfolio compared in 2016 to now, we've had almost a 40% increase. And I think everybody who's been writing grants knows the pay lines haven't changed, right? Except to go in the downward direction. And yet we've increased our portfolio by 40%. It's really incredible. And our other NIH funds that are also peer reviewed is up by 23%. So what a huge difference the program is between now and where it was in 2016. Remarkable growth. So then my priorities going forward in my role is to support the program leaders in growing the program. So setting that direction, and that's set by you, the members, about where we're going to go. And it's my job to make sure the program has the resources it needs from the Cancer Center in order to do the things that we want to get done. To continue to expand PHSR to growth to meet your needs as well. As I said, in 2016, there was not a shared resource dedicated to population health. Now we have one, and we can grow that in any number of directions: data science, behavioral measurement, the things that Jamie's interested in. And the Cancer Center has also made huge investments in data science, and we'd like to expand our ability to work in that area as well. And I think it'll help with interprogrammatic collaborations. Recruit the new AD to get a really good leader in that will continue to develop and grow population sciences, and then work with our Cancer Center leadership to implement their strategic plan. In the last year, the Cancer Center has gone through this massive strategic planning process, and COE and CPC has been a cornerstone of that plan. And my job, I think, is to continue to make sure that we stay there and that we're integrated throughout the DNA of the center into its translational work, its basic science work, and there's opportunities for us to continue to grow, continue this trajectory, and to be relevant and to make a difference in the lives of people who suffer from cancer. So thank you all. Enjoy the retreat. Big thank you to Jamie and Raj and Ellen for all of their work at organizing our retreat and bringing us together. So thanks.
Thanks, Kathy. Appreciate that. Any quick comments or questions, one or two, before we head into the sort of additional overview? Russ has put a thing in the chat, and I encourage folks to use the chat as well. Throughout to increase the exchange, and anybody feel free to chime in. But I will be mentioning the Four Corners Collaborative that Kathy has put a lot of effort into establishing and moving forward. And I'll say a little bit more about that as a real opportunity for us to partner with organizations, other NCI designated cancer centers throughout the region to, to share data, to partner on new projects, to get together and rally around. There's lots of opportunities for community outreach and engagement in that area. And even though some of, we experience some of our underrepresented groups in this area, if we come together as 4 cancer centers, or 3 out of the 4, or 2 out of the 4, we can really leverage those communities and address their needs and partner with them much more effectively to achieve the kind of sample sizes or project sizes we need to be competitive at the NCI for new projects and new funds. So that's so far a huge amount of effort, and I think it's just now starting to pay off because Kathy has led one of the initial paper efforts to produce some data out of that collaborative. And I was able to attend my first one, was really impressed by the collaborative nature of the different centers and such a strong commitment to addressing the disparities in the areas that we share and with the communities where we have a tremendous amount of overlap. Just to clarify, it's Huntsman at Utah, the University of New Mexico Comprehensive Cancer Center, and then the University of Arizona, and of course, Kathy's leadership role in terms of here in Colorado. So it's a great opportunity. Thanks for bringing that up, Russ.
And then there was a comment from Evelyn about the rural grants. So as we all know, the state of Colorado is primarily rural, and it's an area of emphasis to try to ameliorate disparities between rural and urban populations. It's certainly an NCI priority, and both Evelyn and Jamie applied for grants in this area, and it looks like both Evelyn and Jamie will get funded, which is pretty astounding. So I really am proud of their efforts, and it's great. And I don't want to say too much more about it because it will jinx it. And so it's really best not to talk about grants until we get the NOA, but it looks like they both will be very successful.
You too, Kathy.
Thanks, Evelyn.
You got a big grant with Marcelo.
Yep. Yes. Yep. That's one
the
of the
difference is you already received it.
Yeah.
Yeah, and we have to wait on pins and needles for NCI decision making. So pretty exciting. Betsy posted a question about the data science resources and then relevance to behavioral science. Those are kind of 2 separate things, Betsy. We are, we're continuing to enhance our partnership with Compass to make sure that that all of our investigators have access to the electronic health record driven data here at the University of Colorado. We had a meeting with one of the new hires who is going to be leading Compass. Marcelo and Elizabeth and I met with him yesterday, and it was filled with enthusiasm for how we can partner and leverage that data set so that we can develop dashboards so that if you're writing a new grant on hematologic malignancies, that you could look up a dashboard and get all the latest information about the last couple of years about the number of diagnoses and burden that and the care that we provide here at Colorado, and then combine that with the data that we have access to from the registry that our predecessors, Kathy, when she initiated this, and Evelyn has shepherded with, that's all continues to be available in terms of those data sources, as well as elements of the all payer claims database. In terms of the behavioral science, that's one of the things that's going to be hopefully emerging over time. And that is bringing more qualitative and some survey data resources and clinical recruitment inside our clinic so that we can retain those skills for folks, train someone to do this work and have them work on multiple projects. So adding some additional skills and resources to the PHSR to allow more clinical and community work that extends it beyond the data science expertise that we currently have. And so we'll be rolling that out over time and as resources allow and as the pandemic allows, which has obviously put a little bit of pacing question about how quickly we can do that. But this, hopefully we would have personnel that would be available to folks to support their research projects and have that. Bob?
Jamie, I just want to interject a little bit on the data science side too. So the School of Medicine has made a huge amount of investment in growing data science on the medical campus. And they've just recruited a person to lead that effort from Penn. His name is Casey Green, and the Cancer Center has contributed considerably with that package. And really, it was an effort that started out in the Cancer Center. And we were able to convince the Dean of the School of Medicine to go out and invest into a bigger leader in a campus-wide effort. And so now we are in the process and getting really close to recruiting an AD for data science in the Cancer Center. We hope that offer can go out soon. It looks like the candidate's excited, and it's somebody who's excellent, very collaborative. And in interviewing him, he was extremely interested in working with population health and with clinical data science and to bring it all together. Up to this point, our data science effort has been bioinformatics, which is kind of RNA-seq and making the donut, sort of just processing these fairly routine sort of requests, and hasn't focused on clinical data or population data. And this new person that we're going to bring in is going to grow that and be able to include us more broadly. So start thinking about all of the machine learning type of questions and things that you could have and use our data more effectively.
And Bob had mentioned that Ian Brooks is the person we met with. Thanks for helping me remember names. And so we were able to meet with him. And one of the things that he brought to us in the discussion was an interest in social determinants of health. Which was heartwarming, refreshing, exciting, all in that, and that his interests are, expand beyond some of the things that our colleagues do, but also some of the things that we are interested in terms of population health and disparities and some of those areas, and to make sure that our efforts to partner with Compass are also well represented in data in that space. So these are all very exciting things that we'll continue to work on. And as in speaking for the PHSR, we'll continue to try to push out some materials as new resources become available, as some of these dashboards get set up. Give us some time, of course, but these are things that are on the horizon, part of the training plan. So please continue to use the chat, but I'm going to go ahead and transition to start talking about where we are with the state of cancer prevention control, and you can see the rest of the list today. I appreciate a little bit of emphasis on trying to keep on time, but I'm not really that worried about it. We'll just use our time as best as we can. And if we have to cut Russ short and just let him talk for 30 seconds, that's probably more than enough anyway. So moving on, I want to emphasize that this is the presentation that Raj and I developed and gave at the EAB meeting earlier this year. Much of it is not updated. We just wanted to give you a sense of what was presented, and I'll go through some of it quickly because some of it's very familiar to us. But I do want to give you an idea of what we were seeing, how we were seeing things, and Kathy's provided some updated information that's even more impactful and shows a really strong trajectory for the program. And it was great to be able to come in and within the first couple weeks present a whole bunch of great news to our EAB and pretend, so totally the Alex Trebek effect. I had nothing to do with it, but I get all the credit. So it was really great for me. So going on, go ahead and get started. So Raj and I co-lead this program. Raj is obviously an internationally recognized leader in the areas of chemo prevention and dietary and synthetic agents. He's been at the helm of the program for over 11 years now. My area of research is in lung cancer prevention and control, focusing in on both screening implementation and survivorship. And I was previously in similar roles at the University of Kentucky Markey Cancer Center. And we do share responsibilities for shepherding the package of aims that we put together. We organize the speaker series and look for and disseminate opportunities for new research, and as well as doing our best to facilitate intra and inter-programmatic collaborations. Those are two terms that are vitally important to the NCI in terms of how much do we publish and secure grants together as a CPC program, as well as how much do we reach out across the programs. Are we partnering with our biology and biochemistry and clinician science colleagues to make sure that we're having interdisciplinary impact? And that extends outside the cancer center as well, to other NCI designated cancer centers. Those are strong metrics that when we publish with a group at Memorial or publish with a group at Huntsman, that these are good things that the NCI likes to see. And so if you have that kind of work and those colleagues at those institutions, make sure it gets on our radar so we can highlight that in our work and write-ups. The three aims that we've modified a little bit since this time are first to develop and evaluate novel prevention approaches for cancer. This really includes both chemo prevention and behavioral interventions. We also have worked to highlight our work in disseminating those interventions in population-based settings, and then to leverage our data science expertise that works to identify and reduce disparities in our cancer survivor communities, as well as doing health services delivery and policy research to inform better cancer care, cancer prevention control overall. And you can see it's sort of a develop, disseminate, and extend the broad impact of our science into the communities. One of the standard things we need to do during this is to recognize our previous scores and acknowledge and clarify how we've worked to address those. And you can see that the previous review in 2016 identified some strengths in terms of addressing the cancer continuum, work on chemo prevention, particularly highlighting Raj's very impactful work in that space, then translating some of that work into clinical settings, and then establishing the working relationship with CDPHE was one of the things that we were given huge kudos and credit for, and working to sustain that. However, that was paired with some limitations and some feedback that led to our very good score. Just to put things in context, very good is not very good. We really want to improve upon that and expand. Of course, this is a very rigorous and difficult review, and we really want to work our way up to some of the single word descriptors of our work that involve, outstanding and excellent and those kinds of things. But there had been some funding declines at the time. There had been some questions about the stability and the leadership and planning and vision, as well as even though they'd said that we had expertise across the cancer continuum, that was paired with a critique that was a rather diverse and unfocused portfolio of research that really wasn't leveraging each other's strengths to identify unity and have greater impact. But we've responded by increases in funding, and we importantly noticed that much of this increase in funding was homegrown. It was not recruited impact. It was really homegrown impact from the scientists who were already involved in the program and having additional success. There's been some leadership changes. Kathy has stabilized the program in terms of building on our strengths and looking for our opportunities. And one of the key features of what she's done and what the leadership has done is the PHSR shared resource, bringing additional capacity and sort of a home base for both our data science and some of our clinician scientists to build their research programs, particularly in health services and health economics research. And then the addition of Evelyn and her focus on community outreach and engagement, creation of that office has really helped us strengthen our connection with our community. At this time, we had 54 members that distribute about 80% full and 20% of those are mentored. We're really highly matrixed here in the Cancer Prevention Control Program. 24 different departments are represented, 8 different schools, all of our consortium institutions at that time. Although the vast majority of us hailed from the Anschutz campus, we did have substantial representation from Boulder and CSU. Since 2016, there was 9 new full members, and we've expanded since then. And then there were 10 very important mentored members that came on board since that time. And this is all a nice mix of clinician scientists, data scientists, population health, behavioral science, and environmental science, all represented in our expansion and growth and leading to greater impact. This slide is one of the key ones that NCI metrics looking at our dollars that we have secured, extracted out of Washington and Maryland. In terms of at that time, we were at $6.9 million in peer-reviewed research, including 2.9 across 23 different awards from NCI, 26 from other NIH institutes, up to 3.2 million, and some other peer-reviewed funding. This at that time was a 28% increase in peer-reviewed funding and a 23% per capita peer funding for each of our members. This is, as Kathy noted, really strong growth for a time when funding has not substantially grown and pay lines have not gone up. Another is our team science strength. You can see that there was substantial increases in multiple PIR awards from, a tripling from 3 to 9, and many of those from NCI, and other team science awards, a doubling of those, and 4 of those from NCI as well, showing that we're increasing our collaborative and the amount of touches we have engaging each other and integrating our science across different disciplines. In 2019 alone, there were 10 new awards, 6 of those from NCI, and 12 collaborative awards with NCI, other NCI designated cancer centers. And like I said, I want to build on what Kathy mentioned, the data is even stronger. I included a slide a little bit later on to highlight some of the new research, but the new numbers are looking fantastic and really represent the research that everyone has been doing and really impactful stuff. So all good news. You make our jobs easier. Kathy also noted that by this time we had 450 publications, 32% of those were collaborative, and 13.4% had impact factors greater than 10. This is actually a pretty high rate for cancer prevention control programs. Not a lot of our journals reach that impact factor of 10 parameter. So Raj and I also focus on those that have an impact factor of 5 or more, which is commonly or frequently tracked by other cancer prevention control programs as well. And you can see we're at 36.1% of that metric. And so across the map, impactful, total volume, impactful presentations, we're on a great trajectory. And thank you for your hard work. 97% increase in collaborative publications, 58% increase in total cancer publications. And yes, you can see these are all breakdowns that Raj and I get to have fun with and allocate on a fairly regular basis. And if you're excited about doing this kind of work, step on up and feel free to participate. It's great fun going through a list of 600 applications or publications and deciding whether they're cancer related or not, and classifying them. One area where we had to do some fast talking was in our intervention trial accruals. And it wasn't so fast, and we had a very good explanation. In general, you can see, if you look into the green bars, I'll be honest with you, and you can see a decrease in trend in external peer-reviewed clinical trial accruals. But this is really an anomaly, because we had a very large, robust screening trial that was being conducted in the VA. And if you extract that single study from these numbers, you can see that actually we're on a favorable trajectory for clinical trial accruals that was just heavily impacted by that one really strong VA trial that I think was a colorectal cancer screening trial. But if I'm wrong about that, please correct me in the chat. But you can see that we are on a favorable trajectory, and we have launched quite a few new behavioral trials, chemo prevention trials that we'll be able to highlight, and I think these numbers will actually continue to increase. I'm not going to go into each one of the particular stories that we highlighted. This is in many ways the centerpiece of what we do with the EAB presentation, looking at the some of the real highlights of our research. We told the lung cancer prevention and control story that's led by an outstanding group that we have here with Bob Keith, York Miller, Dr. Ghosh, and Dr. Merrick. In terms of the story that they've developed with regard to the possibility of of an intervention for individuals to reduce their risk of developing lung cancer. We also highlighted Evelyn's terrific work that will continue in all likelihood into a new NCI award, this PCORI grant, to look at lung and head and neck cancer survivors and folks going through care, that really an underserved community of folks, and sometimes quite difficult work to do with this community, not necessarily a group that lends themselves to participating in behavioral interventions, but really strong work from Evelyn in this area. And then finally, also excited about Dr. Laudenschlager and Dr. Bradley's work in cancer caregiving, a real strong example of our merger between expertise and behavioral interventions, and looking at some of the biomarkers and psychoneuroimmunology of some of behavioral interventions, as well as Kathy's work on employment and financial toxicity in that context, bringing together a nice project that will be funded and is work to adapt the intervention to go online so they can still do it in the context of COVID. And so anxious to hear how that work is coming along. One of the other things we do is to highlight our work in community outreach and engagement. And what the story that we tend to tell is the HPV vaccination story. We have strengths and challenges in the HPV vaccination in Colorado, but what we have in terms of our research and community outreach portfolio is nothing but strength, including national leadership, Drs. Dempsey, Kemp, O'Leary, and many others who contribute to this to a very robust research portfolio on supporting vaccination rates. And so we've been working on this issue. It's one of the really strong stories that we have to tell in terms of community outreach and engagement. We also have a robust program in research and supporting our members in terms of organizing our annual retreats, be they in person preferentially or virtually in our current state. And you can see I didn't update it. It was not April 30th, so you didn't miss anything. It is today. And then we also, one of the things that I like that we've done is mini retreats, and we'll be having a mini retreat coming up sometime later as winter approaches with regard to supporting our initiative with regard to pancreatic cancer prevention and control. We have a group of folks who's interested in this, and if you are interested in joining that group, we will be bringing people together, but we chose to focus on getting this retreat accomplished and in the bag before moving forward. But there are, of course, some opportunities with Dr. Del Cairo's work and Raj's work in this area, and adding some behavioral components to that going forward. We also administer the seminar series. We highlight Dr. Kuttner's training grant. We really spend a lot of time focusing on the PHR and the resources it brings. And CPC members have really benefited from the Cancer Center's investment in the pilot funding programs. We do a nice job securing a little bit more than perhaps our fair share of those pilot grants. So continue to do that and translate those into other funding so that we can have a nice, robust return on investment in that space, because that is tracked closely by administration in terms of what kind of the publications that come out of that, as well as the future federal funding or other funding sources that is secured in response to the pilot funding grants. I've talked many times, and Kathy mentioned too, about the value of the PHSR and what it brings and the investment that has been made in those resources. Encourage people to continue to use the PHR, hopefully taking advantage of some of the expanded services. But you can see our members also use the biostatistics and bioinformatics, and some of our chemo prevention colleagues have a little bit more diverse portfolio of using some of the other shared resources. Honestly, I struggle to track what all these abbreviations mean, but certainly we see some of our members using a wide variety of those more basic science, lab science oriented core facilities. This is my one update slide in terms of just in 2020, we've had an expansion of the number of members that we have in our program, with 4 new full members, 3 new mentored members, 5 clinical members, 2 affiliate members. It really shows continued robust interest in our program. If there are folks that you know that are out there doing cancer prevention control research, broadly defined, please let us know. We'd be happy to do a reach out. Stacy helped us reach a new mentored member in the past couple of months with some new pilot funding, or some new funding to work in the palliative care space, and the transition of folks from nursing homes I believe from inpatient hospitalization to nursing facilities, skilled nursing facilities, in terms of helping facilitate the transitions, and particularly with a focus on the care that they, their own care plans, and making sure that their voice is plays a big role in those decisions. And then finally, just like Kathy said, we have so many new grants that it was embarrassingly long list to talk about, but there's new funding in just the past several months from NCI, from the VA, from Joanna's work with NINR that's recently funded. Very excited about that work, and congratulations. So new funding from ACS, even the mentored awards there, palliative care funding. We did pretty well with some of the supplements our team members have secured, as well as other funding sources that are too numerous to list. So in transitioning to what we're thinking about the future, we want to continue to expand the translation of our chemo prevention agents. Lots of hope that we can put these more in patients, and that's exactly what's happening. Talked with Bob Keith about some of the work that he's been working on, as well as some of the chemo prevention of skin cancer by Bob Delaval. So this is great stuff. We've also seen an additional emphasis on psycho-oncology and behavioral oncology, with several faculty members having interest in this area, securing some additional funding. So we'll put a little bit more emphasis in there. And of course, I've already talked about the four corners and the collaboration that's potential there, particularly with disparities-oriented work. And then also, you know, we have an incredible amount of implementation science expertise within our program, but also across campus. And I think we have real opportunities to leverage this within CPC, also in partnering with community outreach and engagement, leveraging the work of Russ and Kathy's P50 and all the great work that's being done in rural communities there. And so there's just lots of opportunities to build. And of course, we need to sustain our efforts to recruit, train, and mentor future CPC leaders. And I will stop there knowing that I'm probably way out of time, but I get excited about highlighting all the work that is being done by our program and by each of our members here. And so I think we've answered most of the question. Kathy posed a question about member. We have, you know, the NCI requires us to have a membership program in terms of and our defined different areas of membership. Our clinical members have slightly different qualifications than our affiliate, than our mentored, than our full members. It comes different memberships had different perks, but basically the definition of a member is someone who's doing cancer prevention control research and has a current funding portfolio. For those folks who do not yet and are early in their career, we often engage them as mentored members. For those who don't have a currently funded portfolio, we work on them with affiliate or clinical members and work to help them achieve funding for their research portfolio. If that's not a goal of theirs, they'll stay as an affiliate or clinical member, but it's certainly a goal of ours to support the investigators as they want to expand their research impact and funding. So any other comments, questions before we transition to our next presenter? Okay, well, let's go ahead and transition to our, oops, I'm getting a little bit ahead of myself, but we'll re-advertise the Ray of Hope event this evening. But I think next up on the agenda, I regret I don't have it in front of me, unfortunately. Is it Russ, are you next, or Emily and Alyssa, are you guys up? Russ.
I'm next, Jamie, I think.
Okay, thanks, Russ. So I'll turn it over to Dr. Glasgow for us to tell us a little bit more about the P50 grant. This is very exciting. This puts us in the in crowd in implementation science and cancer prevention and control, and really a robust program that I'll let Russ tell you a little bit more about. And I'll stop sharing my screen so that he can share his and take off from there.
How are we doing in terms of technical support? Can you see my screen? Can you?
Yeah, we can see your screen as empty screen with a cursor.
The white screen.
Okay, let me try just a minute. I did see I've got the correct one selected. How about now?
Perfect.
Okay, great.
Put that in presentation mode, you'd be all set.
I will try that. Usually bad things happen when I do that, but let me see if I can. I can't see anything. Can you possibly read that now or not?
We can read it, Russ, if you come down a little bit, and then you
like that or not?
well, you can bring arrow. It says slideshow. It's just right there.
All right, let me see. Sorry about this. I'm afraid I don't want to waste more time. See to well, let me try once more. I apologize, Jamie. We got two options. We can either limp along this way, or you can share your screen if you want to.
It'd help if I'd answered not on mute, but yeah, please just go ahead. It's fine, Russ.
All right, thanks. Let's see, I'll try to go through this quickly so we can gather a little time. Just a word about myself for those of you that don't know me. I'm a behavioral scientist by training, and I direct the dissemination and implementation science program at Accords. If you don't know that, you can see what that stands for on this slide. Maybe the most relevant thing for you might want to know about me is in one of my former lives, before I came here, I was on the dark side at NCI, where I was actually the deputy director for implementation science. So I have a little bit of experience from that perspective. And during that time, I had a chance to interact with Betsy Risendahl and some other colleagues, and especially through the CPCRN. But turning to today, what Jamie and Kathy wanted me to talk about is a relatively new P50 center. And its theme, as you can see there, is a paragraph long, but I will let you read that. I'll emphasize a couple things, and then I'll try to unpack that for you. But we have a strong emphasis on pragmatic, and by that I think we mean generalizable and feasible approaches. We have a key focus on cost and value issues. In addition to Kathy, we have two other wonderful health economists that are part of it. And our focus is in rural primary care. Again, I'll say more about both of those. Just briefly, we have the usual administrative organization structure, but a few things that are a little different as well. We explicitly have a network and outreach unit. Our implementation studies unit focuses on conducting pilot studies that are hopefully quite replicable. And then what we call our implementation laboratory, which is a real community partnership with networks that I'll mention. I won't read the names, but you might note there, in addition to Kathy and Jamie, who are a key part of this, Liz Kessler is also a newer member of our team, but somebody we're delighted to have. So what is this about? This is a different type of center than I've seen before, and I think it's new for NCI too. It's one of the moonshot initiatives, but in addition to doing our own research and methods development, explicitly its goal, and at the end of 5 years of funding, is its explicit goal is to increase the capacity both locally and nationally to conduct implementation research in cancer prevention and control. And there's a big emphasis on sharing and collaborating. So I'll save some time to get to what some opportunities might be there. This is the one slide I'd like to take just a little bit of time on, because it's important to kind of understand our worldview and what we're about. As I mentioned, we have a big focus on cost and benefits. And as you can see, the diagram on the right-hand side, we do that through two lenses. One through our RE-AIM implementation science model, which focuses on 5 key factors or dimensions that are important for achieving population impact or public health impact. Secondly, it's indicated at the bottom, we feel it's critically important to take the lens of multiple stakeholders. And by that, we mean kind of using a social ecologic model all the way from patients and families, community members, importantly to what I like to call frontline delivery staff, people that really deliver programs and are often left out when we're doing planning or assessment, all the way up to folks like clinicians, or we focus in primary care. So often those are primary care physicians, but then also decision makers. Last thing on this slide is at the top there, we have a big focus and I think some opportunities for those of you that might be interested in behavioral measurement issues on context domains and contextual factors that drive or influence these RE-AIM outcomes. just a few things I'll mention in bullet points, bold on this slide, is some ways in which our center is different than the now 6 other ones nationally are, first of all, our focus on health economics, as I said, on primary care in rural settings. And we use, I'll mention in a moment, which ones, a couple different primary care research networks. That's really an important partnership for us. Just a little more specifically, when I say pragmatic measures, I like to say that has to do with pragmatic models. These are theoretical or conceptual models with methods, and particularly with some methods for more rapid design and things that may generalize more, and measures there. Parenthetically, I'll be glad to follow up later, but we've started a new certificate program, one of the first in the country in implementation science. Our current research program, each year we have a 1 or 2 different themes about our projects, but initially we're focusing on shared decision making. We have some great national leaders there, certainly including Jamie, and the focus is on lung cancer screening and smoking cessation. Future years will be expanding to other cancer prevention and control activities. I mentioned about costs and benefits. The other thing is, I think we have a strong track record in developing web-based and interactive resources for a variety of different, both patient-facing and primarily researcher, implementer-facing websites. We have an unusual relationship in that in years 1 and 2, we focus on Colorado practice-based research networks, but then we have a strong partnership with a national, this is American Association of Family Practice, national research network that has thousands of practices to work there. I'll note, you'll hear before too long, we're going to have a competition for some small internal pilots that we're able to fund through the P50. So my takeaway messages, I'll wrap up here after one more slide, is that our clear focus is, again, is to enhance capacity, not just to do our own research. Second bullet point, we really would love to collaborate, and we'll be sharing resources, especially on those areas in bold. And again, one of our criteria for success, as it is for you, is on these key partnerships and collaborations there. In particular, off the top of my head, I've listed a few things here and would love to hear from you all, either today in chat or feel free to follow up. But I'll mention 2 things that came to mind as Jamie or Kathy were talking. One is in terms of behavioral measurement. That's an area that our group focuses a lot on. I think that's an opportunity. Second, in terms of collaborating with other cancer centers, we are one of the Moonshot grantees. And I think there's a lot of not only opportunity, but almost pressure from NCI for us to collaborate with others. And one of the initial ones might be with the C3I tobacco programs there. I hope to have some news about that before next month or 2. But as you can see there, other bullet points I don't need to go over, other than I'll maybe conclude with a focus on aging and cancer. We have a couple geriatricians with us, and we've already had one recent success. I think will be talked about a little later with your aging and cancer group on a recent supplement there. So I think that's my time there. And Jamie, I don't know, I can't see the chat right now, but I don't know if we have time for 1 or 2 questions or if we should move on.
If there are 1 or 2 questions, please throw them out. I think we'll take the time. Russ, could you, I'm going to challenge your memory here, just in case folks have collaborators at some of the other institutions that have this similar center grant. Can you remember what some of the other places are?
Oh man, I can't remember my own name, Jamie.
Um,
Or what? But let me try. Maybe Kathy can jump in here too. There's just been a recently funded one at University of Pennsylvania, which was a surprise to everybody. Harvard has one. Both Washington University and University of Washington. Wake Forest has one, and Kathy or Jamie, I don't know. I don't know if I'm one short or not, but
you got the ones that I can remember too, Russ. Um, but suffice it to say that, you know, there was really a lot of there's a lot of opportunities there, and you know, with lots of skills, and one of the things that particularly for the economists, doing some really interesting work on you know, costing. It's outside of my expertise, but I'm learning, and really think there could be some innovative things to help programs, you know, think about developing better and more effective and cost-effective approaches to implementing some of the things that we're most concerned about, in particularly in lung cancer screening, because that's what this grant is really about, lung cancer screening.
That's an inside joke for those of you that don't have it, if you didn't catch it. I'll just close here. I know we have a lot else to get, but I will say some of our other themes and our future directions here are a focus on not only cost and pragmatic approaches, but on sustainability, or programs that can both be sustained over time, not go away when the research does, as well as generalizable. A strong focus, both this group nationally and ourselves, on health equity, especially through the rural consortium, and then also on this emerging area within implementation science on adaptations. So thanks very much. I'll see if I can stop sharing here. And
well, thanks, Russ. I appreciate it. Exciting opportunities for everyone, and appreciate you and Kathy's leadership on securing that opportunity for everyone. I will transition to introduce Emily Cox-Martin and Alyssa Kova, who are fabulous psychologists and clinician scientists who are doing some work in behavioral oncology, and in many ways leading our efforts to have a bigger footprint in that space. And so done some very interesting work with some pilot funding, and so interested to hear what kind of resources they're bringing to the table and helping us expand our portfolio of work in this space. So if one of you guys wants to take control and present, we'll let you do it.
Excellent. Well, Elisa, you're going to share our slides, but in the interest of time, while you're doing the technology portion, I'm just going to start chatting. So we're talking today about a project we call Connecting Colorado, which is a website that we've been developing since about November of last year, so over the past year, with the goal of really improving dissemination of behavioral oncology research within the catchment area. And we got some, like Jamie said, some pilot catchment funds. And Elisa and I are not website development experts. We are clinical psychologists, but as Russ and Jamie and a lot of other people have shown us, clinical psychologists can really just go anywhere they want, it seems, these days. So we knew that behavioral oncology as an area of research was growing here. And we really wanted a resource not only to disseminate our research that we're producing here in the catchment area and at the University of Colorado Cancer Center, but also an interactive resource where patients could begin to find out how they could participate, how they could engage with behavioral oncology research a little bit better.
All right, that's me. So in setting out to develop this website, we took a 3-phase approach. And the first step was really to connect with existing resources on campus, to really take advantage of the knowledge and just skills that are already here. So we connected with the Cancer Center website development team. And we're really lucky in that we were able to capitalize on just the migration of the entire Cancer Center website from one platform to another. So there was a lot of engagement and enthusiasm in building our project. And this team really offered us a lot of guidance on kind of how to build a website that's consistent with the CU Cancer Center brand. And we established an outline for how content would be developed and uploaded onto the website. We were also fortunate to connect with the Accord's Dissemination and Implementation Science Core. We presented at their Works in Progress meeting to identify kind of first steps. You know, we have this funding, we have this idea, where do we go from here? And the takeaways from that meeting really were the importance of integrating theory into our process for developing the website. And so we were kind of introduced to the technology acceptance model, which is an information systems theory about how users come to accept and adopt new technologies. So we use that kind of to inform how we develop this website. And then one of the other things that was really helpful about that meeting was talking about always kind of designing the website with sustainability in mind. You know, how are we going to advertise it? How are we going to connect others to it? And how are we going to keep it going? And then we also worked with the data to value, or the DTV dissemination core. And they really helped us to refine our methods for connecting with stakeholders. That was a huge part of our process, and really led to some, what I thought were some surprising findings that hopefully help us to develop a better product. Okay, so we worked with the dissemination core to develop interview guides, focus group guides. We conducted focus group role plays with the whole idea of holding all of these great events to connect with our stakeholders in the second half of March 2020. And so we all know what happened then. So we had to do some quick thinking on our feet, adapted our process to accommodate just all of the changes from the pandemic. We made a plan to connect with stakeholders, and that was, from looking kind of at our networks, but also talking to people in our networks about who we should talk to. And then we connected with cancer patients and caregivers across the catchment area. One of the things that was really helpful in that is, initially Emily and I just planned to, to recruit from our clinic, and then we stopped seeing patients in person. So we weren't handing flyers. We'll probably never hand flyers to anybody ever again. But we were very fortunate to connect with the Colorado Cancer Coalition. And they were extremely helpful in advertising our project on their listserv. And so we really were able to find a really diverse group of stakeholders to inform the website development. And then the third phase, which is still ongoing, involves actually developing the website. How do we build this? So developing the content, also with a plan for maintaining that content and keeping it relevant, and then a plan for stakeholder evaluation of the website. Okay, so we ended up conducting 14 interviews with professional stakeholders, and that included oncology providers in the cancer center, physicians, APPs, I think maybe some nurse navigators. We also worked with, peer researchers as well as clinician scientists. And some of the themes that emerged from those interviews was the importance for the website to be usable, for it to be easy to navigate. And you'll see a lot of these suggestions, how they actually were incorporated into our website later on. They also talked about the importance of keeping the website fresh, right? There's nothing worse than clicking on a link full of old, outdated material, right? We want to be able to connect people to ongoing studies. So how do we develop a process where we're continuing to, find out about all these, great new studies that our colleagues are conducting in Colorado? And they also really emphasize the importance of making sure everybody who visits the website gets something out of it, right? That it's not just, I clicked on this, none of the studies apply to me, I'm never coming back here again. How do we make sure that everybody gets something from this website? And then we worked with 15 cancer patients and caregivers over the course of 4 focus groups and 2 individual interviews. And you can see here that we had a really nice range of cancer diagnoses. So of patients who participated in our group. As with a lot of our research, participants were mostly women, but you know, they show up. So we also had a great range of participants across the cancer continuum. We had patients who were in active treatment, in extended survivorship, as well as patients receiving end-of-life care. And one of, I think, the big findings from these focus groups is somebody who identifies as a psycho-oncology researcher, is that patients hate the word psycho-oncology. They hate psychosocial oncology. They didn't want to see it anywhere in the website. So we kind of quickly made some changes to incorporate that. That's why we eventually settled on behavioral oncology as the how we describe what we do. But we really wanted to make sure we emphasized that this is research that focuses on whole person care, at the advice of our stakeholders. And they also echoed the feedback of the importance of having support resources available.
So instead of just taking you to the website, which you are more than welcome to do. Actually, if you literally Google University of Colorado Behavioral Oncology, it'll be your first link on Google. I just did it. But I always get a little cautious of trying to alter off the slides. So we're sticking with the slides. So you can see we have about 5 major parts to this website. So first of all, Connecting Colorado homepage is where you land when you first link, if you want to take us there, Elisa. And and so again, a lot of the format was done to keep on brand and be usable. And we opened by just sort of discussing what is behavioral oncology. We got this feedback a lot from our participants, sort of, what are you talking about here? And of course, everyone in this room hopefully understands that particular area of research that we live in. But we wanted to have it really front and center on the homepage. You'll also see we have a website feedback survey, and this gets to part of what Elisa had already previously alluded to, and we'll talk about a little bit about it being iterative and still in process of growing. A little further down on the homepage, you'll also see, if you navigate there, that we talk about how it was developed, Elisa and I, and our role in it. And again, this was really feedback from the patients and caregivers saying, we want to know who's behind this website. It helps us to know that you're faculty. It helps us to know that you have degrees in an area of this research. So moving on to our current research opportunities, this was really one of the biggest parts of the website that Elisa and I were interested in, was really essentially using this as, hopefully in the future, a recruitment tool. And gosh, when we first thought about this, COVID was not on my mind back in November of 2019. But Elisa and I said, you see those flyers all over Anschutz, in the elevators and in the hallways. And what if we could just tell our patients that we see clinically, hey, go to this website, right? And it lists all of the different studies. And here you can see we have a number of studies posted. So this is from a REDCap survey that we sent out last quarter. We sent it out to, I believe, about 28 identified behavioral oncology researchers. And we really used almost like a network analysis for this, well, not network analysis, network procedure, where we sent it out to the people we could immediately brainstorm. And then we asked everyone we sent it out to, who are we missing? Who else are we sending this to right now? And that's part of this presentation too, is that if we missed you, if we missed somebody, let us know, and we'll be trying to do this quarterly and update it regularly. So then the next part that we have on this is our research findings. And our research findings, again, is something Elisa and I were really interested in. It's built out of when your participants say, how will I know what happens with this study that I took, for my RCT, 12 weeks to be a part of. And so we really wanted to have a platform where we could share our results with our participants, but also beyond just our own home team here, we highlight different updated literature from the field of behavioral oncology. We actually have 4 categories. When you see it, there's sort of like these tiles that you can press on. And right now we have it grouped as treatment and symptoms. This is things like fatigue, pain, nausea. We have lifestyle, which is where our physical activity and nutrition people sort of live. Caregiver was a big piece. And again, that came from feedback from our group. It's a growing and important part of behavioral oncology. And then of course, mental health. We have an FAQ section, again, 100% homegrown from our stakeholder engagement. One thing Bethany Kwan told us, who helped us with our dissemination and stakeholder engagement plan, was you can create a great website, and if they don't want it, they're not going to look at it. And so this was something they asked for, and it really, it's a place for definitions to live. It's a place for information. What is a clinical trial? What is an RCT? What is treatment as usual? Will I be billed if I do your trial? All of these things that hopefully build the informed consent for our participants in the catchment area. And then one of the last pieces of the website is a resources section. Elisa and I really wanted to focus on behavioral oncology research with this website. And at first, I can speak for myself that I was sort of like, oh, I don't really want this to be clinical. But the truth is that both our professional stakeholders and our patient and caregiver stakeholders really wanted to have this available all in one place. Maybe they come to look at research, but if they can also find support resources, doesn't that make it sort of a more comprehensive place? So here we have local, such as what we offer at UCH, other options in Denver and in Colorado, and then also national support links like through ACS.
Okay, and so we also, had to think about what happens to this website, right? How do we keep it going? And so we developed a plan for the sustainability of this website. First of all, we want to know if people are using it and what they think of it. So we embedded an evaluation survey into the website. Probably doesn't take more than a minute or 2 to complete, but it's based on the technology acceptance model. And we used a questionnaire that looks at user satisfaction, how usable the website is, and also allows us to get an idea of who are our patients or who's looking at this website too. Are they patients or caregivers? Are they living in Denver or out in the mountains? So we get an idea of kind of who we're catching here. We're also planning on looking at the Google Analytics from the website. So how much time are people spending on the website? How often are they visiting? What are they clicking on? So that can kind of further inform, is the FAQ actually useful? Do we need to make changes to improve the website? And then we also have plans for continually, reaching out to our research collaborators. So keep an eye out for those links from us to get an idea about new studies, new findings. And we're also planning for quarterly, just updates of, new publications from our research partners, as well as from those top journals. And that was something that actually Emily and I've really enjoyed doing, kind of connecting with the field and figuring out, what do we want to share with our patients across the catchment area. And that's all we have planned for today. We'd love your feedback. This is an iterative process. It's ongoing. We want to hear from you about how this can be a tool for all of us here. We'd like this to be something that's an ongoing collaboration in the Cancer Center. So We're happy to take questions, but send us emails. Thanks, everybody.
Thanks, everybody.
Thanks, guys. I appreciate your comments, and that we've had some chat going on. One of the things that I wondered is this: could this be sort of a registry too? If people wouldn't, there's a listserv function I saw that people could sign up, that you would send them, but could people actually add their name to a list to be contacted if new studies came out, or something like that? Is that a function that you've considered?
That is sort of what our listserv is gaming to be.
Okay.
Honestly, Jamie, we have some very future-oriented big hopes and dreams for where we'll go. Things like a newsletter that we would send out to our listserv. This is sort of our initial beta that's out there, and we're going to see how people respond to it. But again, using it as a tool for recruitment, we would love it, for example, if people could begin to put it in their dissemination plans for their grants, right? I mean, really something that we can say to our funders, we have this is how many people are on this, registry or listserv. Here's who we send this newsletter to, and here's the response rates we get.
Yeah, that's a real nice piece, particularly when you don't need, representative samples, if you're doing things like you're already doing with usability testing, and you just need an engaged human who's interested in providing you feedback and doing some things, or qualitative work that you need their experience more so than so it's just a really nice opportunity. Last question, how do people get a hold of you to post their new study that they just launched?
Any way you want, all the ways,
Okay.
all of the ways. So right now, Elisa and I do have a REDCap survey. I hope that some of you on here got it. I think some of you filled it out and sent it back to us. So it's already gone out to hopefully a number of you. But if you didn't get that REDCap survey, that means that somehow we blipped and we missed you. So tell us, and we'll put you on our list, and then you'll get it.
All right. Well, good stuff. And thanks, guys. And continue to post questions. If you have them, we can keep the dialogue going in the chat. But I want to transition to Evelyn. If I think you've already given control of the screen back, but go ahead, Evelyn, take control of the screen. Dr. Evelyn Barreo, who's been our community outreach and engagement associate director at the Cancer Center for a little bit more than a year now, I think, Evelyn. Correct me if I'm wrong. But this is a vitally important part of the Cancer Center. I was at a meeting with the NCI folks who oversee the Cancer Center support grant, who said that in their opinion, the community outreach and engagement associate director will emerge as the second most important person in the Cancer Center after the director. And that is just sort of a signal in terms of how important NCI believes it is to have a strong footprint in our community. And the Cancer Prevention Control Program is perhaps the most amenable to that. It fits our principles and what we want to be doing already. And no pressure, Evelyn, it's all on you, but we're all confident and know that you're excited to be doing that. So I'll turn it over to Evelyn to talk about the Community Outreach and Engagement Office and the work here at the University of Colorado Cancer Center.
All right.
Thank you very much. Thank you very much. Hopefully everybody can hear me. Great. I appreciate the introduction, Jamie. No pressure. And I would say it's still to be seen how much community outreach and engagement, COE, really gets value over the years. But at least for now, it is highly important for the NCI. And I believe we are doing quite a bit at the University of Colorado Cancer Center. And so my goal today is to describe the catchment. What is the cancer burden, risk, and disparities in the catchment? And Elisa and Emily use that term For our cancer center, the catchment is entire state of Colorado. And that is not always the case for other cancer centers where they may have several in the state. And so they have a portion of the state. For us, is the entire state of Colorado. So I'm going to try to also catch us up with the agenda. I will perhaps just give you an overview of the catchment, and I'm happy to answer questions. Let me start by telling you what the Office of Community Outreach and Engagement is. I oversee the office, and we aim to have 5 full-time staff. We have 4 at the present time, hoping to hire a cultural competency and literacy coordinator to help all of you with engaging particularly Hispanic populations with translation, as well as making sure the protocols are culturally appropriate and competent. And then we have some part-time staff that includes Ellen and Amy from the PHSR. The aims for the Office of the COE is to provide you with comprehensive up-to-date data on the catchment, on the cancer burden, risk, and disparities. And that's what I will be doing today with my presentation. We also will assist or are assisting the Cancer Center with enhancing and disseminating the Cancer Center's research for impact. We're also assisting the Cancer Center on engaging communities in science, education, and advocacy. But as I said, I will be focusing on the first aim. I will be presenting some data on cancer health disparities in Colorado. The NCI defines cancer health disparities as differences in incidence, prevalence, mortality, and burden that is related to adverse health conditions. So this is the key aspect of this definition, that is not just differences, but differences that can be explained by low socioeconomic status, lack of access to cancer prevention control, treatment, lack of health insurance. And it's particularly affects certain populations in the US, and those are called disparity populations. And these are some examples, including racial ethnic minority populations, rural and frontier, poverty-stricken children, older adults, and LGBTQ+. And I will be talking about the first 3 groups as an example of disparities in Colorado. So some of the disparities by race, ethnicity, and this is in collaboration with the PHSR. They produce this data for us. And you can see these are the 10 most prevalent cancers in the US and in Colorado. And if you see the first side of the graph, you see that in Colorado, the rates are actually lower across cancers compared to the rest of the US, which is the gold bar. But when you look at Hispanics compared to others, Hispanics in the US is the opposite. And it's almost higher for all cancers, all 10 cancers, but significantly higher incidence for breast, lung, and colorectal cancer. I know the star is really small to see, but same thing with mortality, lower for non-Hispanic whites compared to others in the US, but for Hispanics, lung, breast, and colorectal, the mortality is significantly higher compared to other Hispanics in the US. And these are some really cool maps that Amy from the PHSR has produced for us. And here I'm presenting the one that I believe is easier to understand. The darker for each of the counties, the color is, it signifies a higher percentage of late stage breast cancer diagnosis for Hispanics. As I mentioned, compared to the rest of the country, that we have higher incidence and mortality. And some of it may be explained by late stage disease. And I will be presenting other maps. And I think what I'm trying to illustrate is that there's certain counties, particularly in rural counties, where a large percentage of Hispanics constitute that population, also have late stage disease. And here is the map for colorectal cancer. We're also looking at colorectal cancer across the Four Corners area. That is something that Ross had asked, and we're finding some similar patterns. These are just late stage disease. Some of you, like Betsy, are leading like the colorectal or the Colorado Cancer Screening Program, really focusing on colorectal interventions, colorectal cancer interventions. This is just showing you how some of the states, some of the counties in the state are affected by late stage disease for colorectal cancer. And this is for lung cancer among Hispanics, late stage disease. So if I go quickly, you would see that some of the similar counties get affected by some of these disparities. The next map shows you a combination of stage as well as incidence and mortality. And the map on the left, the blue shows the darker the blue shows more disparities for those counties. And this is produced by the Colorado Department of Public Health and Environment. And then here on the right, you see the map that was produced also by Amy from the PHSR that kind of shows the density. The darker the color, the higher the density of the population is. But the lighter shows the more frontier and rural counties, and then the shaded area just shows poverty. And you would see a poverty and where at least 25% of Hispanics live is the teal dots. And you can see how in the lower corner, south corner of the state is where a lot of the rural and frontier counties are that experience most of the disparities, and also where quite a bit of the Hispanic population resides. So there is an intersection of cancer disparities being more pronounced among Hispanics who live in poor and isolated counties in Colorado. The next table just kind of shows you a summary of analysis that have primarily been led by Kathy Bradley, as well as the PHSR, trying to assess and characterize the needs of the catchment. As I mentioned, worse disparities for rural. We see higher incidence, mortality, and burden for Hispanics, particularly lung, breast, and colorectal cancer, and poor, particularly where poverty, rurality, and Hispanic intersect. Then the top four cancers are very similar with other states, with melanoma being higher in our states than other states. And it tells you there what is the incidence and mortality for both men and women. And here are some of the risk factors: tobacco, HPV, low cancer screening. And actually we expanded the list also to talk about environmental susceptibilities, such as high exposure to UV rays, radon, and other pollutants. But here you can see that in Colorado, we have a higher smoking rates than the US, and is higher among youth, although the United States, Arnold tells me, and others, that the states are catching up with Colorado. And HPV, as Jamie mentioned, tends to be low, particularly among young adults and those who live in rural areas. And low cancer screening for those who are poor, who are Hispanic, and those who live in rural areas for breast cancer, but very similar for colorectal cancer as well. So what are some of the cancer disparities? What are some of the factors that are leading cancer disparities? Screening and timely treatment. And I will go quickly over some of this. This is national data that shows that Hispanics have lower rates of colorectal cancer. But if you actually start looking at income, you would see that Hispanics who live in poverty, have lower colorectal cancer screening rates. Women who have been treated for breast cancer who are Hispanic also have lower rates of being treated within 1 year of diagnosis, and it also varies depending on the subgroup within the Hispanic population. Access barriers, as many of you are aware, lack of insurance is higher for Hispanics compared to whites and non-Hispanic Blacks in the US. And actually with COVID, that actually has increased. The data is not shown here, but I did another presentation on the impact of COVID on Latino cancer, Latino disparities, and just seeing a lot of Latinos losing their insurance as a result of COVID. Same here with insurance, lack of financial or lack of insurance resources. A higher percentage of Hispanics lack financial resources or insurance. And you also see that is a higher percentage of uninsured Hispanics. This graph just kind of shows you those who needed care, but sometimes or never got care. Hispanics as well as Blacks, a higher percentage compares to whites, and is higher for those who lack insurance among Hispanics compared to those who are publicly insured or who have private insurance. Sorry if I'm going a bit fast. Hopefully the slides can be made available and you can just look at them more carefully. My take-home message to all of you is the importance of conducting cancer disparities research. And what I tend to mention is that you don't need to be an expert in cancer disparities research to do cancer disparities research. You just need to incorporate it in your research. And hopefully, as we move towards meeting the needs of the catchment, we will have more and more investigators, including cancer disparities in their work. When we talk about cancer disparities research, it really needs to be across the board. We need to be conducting groundbreaking mechanistic research. These are our basic sciences that can lead to scientific discoveries that will help us reduce disparities. Those that conduct translational research leading to discoveries and approaches that could change the paradigms of cancer care to reduce disparities. And then some of us who are in CPC conducting more groundbreaking population health research to prevent cancer, promote equity, and shape policy and healthcare to improve cancer outcomes. And then my last slide is a statement, a position statement from the American Association for Cancer Research, the American Cancer Society, the American Society for Clinical Oncology, and the National Cancer Institute. And I will read this to you and then I will finalize my presentation. Given the looming crisis in cancer incidence and mortality disparities that affect minorities and the medically underserved, it is our collective hope that in this period of cancer research, when significant breakthroughs are being discovered, there will be an opportunity to apply this new knowledge to all populations and thus eliminate cancer health disparities for current and future generations. You will see that this statement is also supported by an increase in call for proposals, funding that is being not only provided by the NCI, but the American Cancer Society. So I encourage you to consider those opportunities and move in the direction of conducting cancer disparities. Again, you don't need to be an expert in conducting to conduct cancer disparities. Okay, with that, I'll end my presentation, Jamie, and hopefully catch us all up.
Well, thanks, Evelyn. You and your team are doing really great work, and I wanted to. I mentioned in the chat that you have some team members who are on the call today, and they bring some really strong relationships with community partners, and as well as knowledge of the institution, how to make things happen here with regard to our community partnerships. And encourage folks to, if you do have community-oriented projects, whether they fall into research or community engagement or program evaluation, to make sure that Dr. Borreo knows about those at first, and possibly can even partner with you with her team on those kinds of things to make sure we're having a really strong investment in our community and making changes that we need to see. Because the level one of community outreach and engagement is being there. Level two is seeing change. And NCI is increasingly interested in level two of the equation. And so that's once again Evelyn's charge to just a small thing of changing the health disparities in Colorado, cancer health disparities in Colorado. So thanks, Evelyn. Appreciate your comments. And
if I may just add, I lead the office, but the heavy lifting is done by our wonderful team members, and I would just like to mention them by name. So as a way of introducing it to the CPC group. We have Daniel Pacheco, who is our program leader for a program lead. We also have, I see Jose Baron, who is one of our community outreach and engagement coordinators. I see Carlo Caballero, who is our patient navigator, or at least our first patient navigator. And I also see Ellen, who is our administrative assistant, and they are part of the COE.
And Sarah's calling in as well.
Who is there?
Sarah's calling in as well.
Oh, Sarah's calling in. Sorry, Sarah. I just didn't see your name, just your number. Didn't mean to leave you out.
Appreciate all the presentations that have been given so far. Thanks to everyone. I'm feeling the call of a nice little natural break, but I know we're a little bit behind schedule. So maybe if we could limit it to 5 minutes and be back and ready to go to launch sort of our special sections on aging and metabolism. And so by my watch, I have 1:38. And so maybe if we could be back by 1:45 and get ready to go for Dr. Fisher's presentation on her work. So thanks, guys, and be right back. Stacy, I'll let you go ahead and take control. So welcome back to whoever's been able to make it back from their quick break. And I want to, I've mentioned several times that the Cancer Center has two cross-cutting themes. One is on aging and one on metabolism. And I think these are two areas where we have particular strengths across all of the Cancer Center programs. And one of the real gems at the University of Colorado is the palliative care program, including the research, the training for research, the clinical operations, and Dr. Fisher is one of the major parts of that. And so we're excited that she's part of the Cancer Prevention Control Program and is going to present some of her research today for particularly the components related to our Cancer Center. So Stacy, take it away.
Thanks so much. So just for those who are not familiar, palliative care is an approach that looks at the whole patient and addresses physical, emotional, spiritual, quality of life related issues related to dealing with advanced illness, such as cancer. We work as an interdisciplinary team. Our clinical service is amazing here. We have a vigorous Joint Commission certified inpatient team and an outpatient clinic as well that's embedded within the Cancer Center. So this is just a brief overview of some of the things that we have going on. I'm not, okay, totally sure how to advance the slides. So the first one, and I saw this, it was great, exciting to see on Emily and Alyssa's website, is the short phrase is the REACH PC trial. And it is a comparative effectiveness study of telehealth versus in-person palliative care. How could we have known in 2017 how important it was to test the effectiveness of telehealth? And never has it been demonstrated to be more important in this really trying time during the pandemic. This study is looking at newly diagnosed persons with advanced non-small cell lung cancer. Patients are randomized to in-person visits of outpatient palliative care or telehealth visits. Caregivers are invited to participate, but are not required. Our local accrual goal is 60 patients, sometime between June 18th and May 2022, although COVID has also changed that timeline a bit. We've currently accrued a little over half of our sample. And there are 20 other cancer centers across the country that are participating in this trial. And the overall national accrual is 1,250 patients. The primary outcome is looking at quality of life. There are a number of secondary outcomes looking at patient-provider communication about end-of-life preferences, length of stay in hospice, caregiver engagement in the visits, and their caregiver-specific quality of life, depression, and overall satisfaction with visits for both patients and caregivers. And this study is funded by PCORI. So if anyone wants to look into more information about it, we published the protocol for the study, and that reference is down there, and I'm happy to share my slides with anyone who is interested. This study was completely closed during the time of COVID, when our campus from about mid-March until about a month ago. And it's been really challenging to resume recruitment. We've developed procedures to do so online, virtually, to recruit, to screen, and to do all this work remotely. However, what we're finding is that this is a study that already is asking patients to have extra appointments. And when we talk to those who have participated, whether it's in the telehealth arm or in the outpatient palliative care arm, people understand the benefit and realize, wow, this was really helpful. I didn't know how much I needed this help. However, in trying to sometimes ask someone who's newly diagnosed with a cancer to do one more thing, especially right now, it's been really challenging. So this is going to be an ongoing trial as we try to work through ways of engaging patients. Another study that's ongoing is, kind of looking at the full spectrum of what palliative care research can be. We're looking at symptom science. This study is one that we are partnering with Moffitt and 4 other Orion centers, looking at chemotherapy-induced nausea and vomiting, to try to look at both GWAS and the microbiome, to try to find and understand new risk prediction models for who gets really nauseated when they take moderately or highly emetogenic chemotherapy. We're doing saliva samples, we are doing stool samples, we are asking lots of patient-centered outcomes to work through the study. We are looking to accrue 530 locally. We're at about 113. And we're of the 6 sites, we're in the top 25% of recruiters. So I think the whole study is a little bit behind. Overall, nationally, they'll be accruing over 2,650 patients. And those are the other sites. I will say, working with Heather Jim at City of Hope at Moffitt, she is an incredible collaborator. And so if anyone is really interested, we're going to have a lot of data, not only of GWAS, but a lot of patient-centered outcomes of chemo-naive patients that are just starting chemotherapy. So if anyone is interested in that, there's a question they wanted to ask about quality of life or function, we're also collecting geriatric assessments for all the patients that are over 65. So we're going to have a wealth of data, and there's a lot of interest in collaboration and partnership. So if anyone has questions and wants to reach out to me offline about participating or getting involved in what might be possible, there's a lot of interest in that from the collaborators. Then I'm going to talk a little about some of my own work. This is a work in progress. We do not have funding yet. Hopefully, I'm going to stay optimistic. The study is called Puente para Cuidar, a bridge for caring. And it combines a lay navigator intervention with a counseling intervention, roughly looking at interpersonal therapy. And it's based off of 2 prior successful studies, the CASA study, which was a study in heart failure patients, actually looking at the counseling intervention, and then my own work in Apoyo con Cariño, which is a lay navigator intervention, working with persons who self-identify as Hispanic, who had advanced cancer, and right now we're finishing an R01 looking at non-cancer illness as well. So taking the kind of best part of both of these studies and combining them into an integrated intervention that is delivered by a bicultural, bilingual navigator, a lay navigator, and a counselor who works with the navigator serving as sort of a cultural broker, and helping work, engaging and activating patients and caregivers into the program. The counseling intervention has a companion workbook that included vignettes. And I'm going to summarize in like a couple of years of work. We had a wonderful pilot from D to V, which has been mentioned multiple times today, to basically take this therapy manual and tailor it to a new population. And, in collaboration with Dr. Borrayo, she really guided our team into taking what was a very dense stories and translating them into scripts that were then filmed as little vignette movies, so that patients can click a link and get to a story that talks about some of the themes that we're focusing on, such as pacing, grief and loss, and other things related to coping. with a new diagnosis. And I've just included just a little still shot. We had great actors who recorded these stories in English and in Spanish that we have ready to use once we obtain funding. We aim to enroll about 260 persons who self-identify as Hispanic, who speak English or Spanish, and have a serious cancer or distress. And it was really, I think, felt really good to say, are we hitting the right places? And based on so many of the maps that Evelyn showed earlier, I feel that we are hitting many of the right places, and our stars aren't very dark, but as you can see, we've got, we're partnering with St. Mary's in Grand Junction out on the western slope, at the San Luis Valley Health Center, which is in the kind of lower southern part of the state, where we saw a lot of those disparities, a lot of poverty, and a very high concentration of Hispanic persons living there. In the Pueblo area, in the central Denver area, and up north. Looking at our intervention to improve outcomes such as depression and anxiety, quality of life, looking at advanced care planning, engagement and documentation, and acceptance of hospice. And we've built a multidisciplinary team of physicians, nursing, psychology, and we are hopeful. If there's also included a reference to our pilot study that we conducted here at university, and we are hopeful. We've had a near fundable score, and I don't know if anyone's had this happen, but a near fundable score. It went to council. It didn't quite make the cut, and then the next time we resubmitted, it wasn't discussed, which was a little bit demoralizing. However, if I've learned nothing in my career as a researcher, is that you just have to persevere. So we will be submitting it again for this October round. And then I also wanted to take, in my final moments, and I'd love to take questions and keep up the discussion that we've been having, is a couple of my just amazing, wonderful mentees. Their names have already been mentioned today, which was also very exciting. Dr. Sarguni Singh, who's in hospital medicine, was funded by the National Palliative Care Research Center to conduct a single-arm trial of the Align intervention, which is a palliative care social work-led intervention that works with persons with cancer who are discharging from the acute hospital to a subacute nursing facility for rehab. It's a clinical scenario we see quite often, which is, well, if you can get stronger from this hospitalization, then you can maybe return and have more cancer-directed treatment. And what she's shown in using SEER Medicare data is that actually very rarely happens. And that for those patients who do go on to a subacute nursing facility, they have lower rates of hospice, and they are more likely to spend more time in the hospital and away from home. And if you ask one thing about patients facing the end of their life, what is most important? Over 80% will say, I want to be at home. She is looking at the feasibility and acceptability of this intervention, and eventually we'll be looking at communication and how goals of care are aligned, including some utilization patterns of care. And Align stands for, I'm not going to quite get the acronym right, but it's assessing and listening to goals and something I can't quite remember, but it's a great acronym. It's like when you can judge a study by the acronyms. Which leads to my segue to Dr. Liz Kessler's work. She's a GU oncologist. Her intervention is called ABC123, which is another great acronym. She was funded with the Career Development Award from the American Cancer Society, and she is in the process of engaging stakeholders and experts through a Delphi process, and Dr. Jankowski is part of that effort as well. To develop a nurse-led intervention for older persons with newly diagnosed advanced bladder cancer. And it's to develop a care plan that addresses functional status, chemotoxicity, and goals of care from the outset of cancer treatment planning. And she'll be looking at, again, feasibility, acceptability, but also some of these other really important outcomes, like how do we How do we think about goals of care, and how is quality of life impacted when we intervene early in this kind of supportive way? So that's what I have to share today, but I would love to have questions or talk through anything more in detail. And I'm always happy offline to discuss any of these studies.
Really strong work, Stacy, and sorry to hear about that story with regard to near funding. I'm afraid I've heard that story too many times. Lately, it seems more so than before. With things going in the wrong direction, despite best efforts to address all the initial reviewer comments, and have no other comments other than condolences and support for that one. But I think my question for you is you guys obviously have the T32 training program as well, that I think either some of our junior faculty have taken advantage of as a huge potential opportunity. And how do we navigate folks to that space to take advantage of that, as well as other collaborative opportunities?
Yes, that would be great. We are, and I think it's one of the things that I love about our campus is how open to collaboration, that is the culture here, and that is the culture that we are trying to foster and create. Some ongoing things that are related to our T32 palliative care and aging training program. We currently have 3 trainees. We are actively recruiting and interviewing for additional ones. Our trainees are also just across all disciplines. So we have physicians, we have nurses, we have social workers, we have psychologists. We meet twice a month in a WIPS, works in progress session on Tuesdays, and invite anyone to join in. We also have an active executive committee, and there is space on it if people are interested. Mark Laugenschlager is part of that as well. Let's see, we have an annual, we have an annual external advisory board meeting, and people are invited to come and participate. And then there's just a lot of individual research. One thing that's coming up that will hopefully showcase some of the other palliative care work going on campus is our palliative care research days. Again, what was a 2-day in-person event is now squashed into a half-day virtual event next Friday. At Dr. Ab Brody, who is a nurse researcher from NYU, will be talking about some of his work. And there's, room to join in. There's poster sessions and paper sessions as well as part of that virtual day.
Well, thanks, Stacy. Appreciate it. Folks want to continue the conversation, head over to chat for that. And I want to transition to introduce our next speaker, Bob Delaval. I have been very familiar with Bob's work for years, based on the fact that I have some good colleagues and friends who were skin cancer prevention and control researchers, but appreciated the opportunity to finally interact with him, although only electronically so far. So Bob's work doesn't perfectly fit into the aging and cancer area, I don't think, but close enough, and I definitely wanted to hear him and have an introduction to more of his portfolio of work. And I've recently become more aware of the chemo prevention work, which sounds really exciting, opportunities to expand our CPC portfolio of work in that space. And so, Bob, one more thing, and also very notably, Bob was recently recognized by the Melanoma Research Foundation for his efforts and received their annual leadership award. And so congratulations, Bob. That's huge. It fit quite nicely into the Cancer Center Support Grant write-up. So thank you for giving me more things to write. So, so Bob, turn it over.
Thank you, Jamie. I hope you can see my screen. Skin cancer prevention, okay, with a picture of the maroon bells and aspen. So thanks for that very kind introduction, Jamie. I'll be talking about VA cooperative studies in skin cancer prevention. And my partner in crime is Professor Martin Weinstock, who is at the Providence, Rhode Island VA and is a professor of epidemiology there. So as you can see, our VA center is much better than their VA center in the pictures. So the largest system of healthcare in the United States is the VA system. It's got 9 million veterans, and they are older, sicker, and poorer patients than most other systems in the US have. Over half of them are over age 65. So I do want to tie in a little bit about aging and cancer, because skin cancer is a cancer of older people. In the VA, we have, unfortunately, or fortunately, only 8% women and 24% minorities. The vast majority of our patients are male. But the vision of the VA is to emphasize prevention and population health. And part of that emphasis is the VA Cooperative Studies Program, which has been around since the 1940s, creating massive multi-center trials. And to date, 2 of them have been in skin cancer prevention, and I'll be talking about those. But first, my personal history of skin cancer prevention dates back to my childhood, growing up in Central California, a town called Madera, and there's the courthouse. And to my mom, here's a picture of her on her wedding day. My mom always emphasized staying out of the sun to prevent wrinkles and skin cancer. And I think it's her influence that led me to my career. But still, I rebelled. When I was an undergraduate at UCLA, majoring in philosophy, I went to the beach, and out of her influence, I got my first sunburn. And I suspect many of you in the audience too have had a sunburn and might be considering or worried about skin cancer in your future if you live long enough. So I'm going to be focusing today on the most common cancer in the US, that's basal cell carcinoma, and the second most common, which is squamous cell carcinoma of the skin. These are over 90% of skin cancers, and they are known collectively as keratinocyte carcinomas because they arise in the skin cell or the keratinocyte. Back in the 70s, there were about 500,000 cases in the US. There's about 10 times that many cases now. And it's one of my career goals, along with Dr. Weinstock, to decrease that trend. So we found out on social media that if we show really gory pictures, people tend to pay attention. So this is sort of our Phantom of the Opera skin cancer panels. These are basal cell carcinomas from Wikipedia and WebMed, and you can see that they can be subtle, which is that little one on the nose there, or they can be not so subtle, such as this one eating up an eyelid or eating up a side of a face, kind of reminding you of Phantom of the Opera. A precursor lesion for the second most common skin cancer, squamous cell carcinoma of the skin, is the actinic keratosis. The basal cell carcinoma that we were just looking at doesn't necessarily have a precursor lesion, but this actinic keratosis is a pre-skin cancer. You'll often have dermatologists or primary care doctors freezing these off with liquid nitrogen in the office. They feel like sandpaper. They're little gritty papules, and they can be small or they can be large. And they turn into squamous cell carcinomas, which can metastasize, and they're most worrisome on the lips and on the hands for metastasis. Now in the talk today, and there's the squamous cell carcinoma indicated by the arrow. On the talk today, I'm not going to be emphasizing melanoma, which we hear a lot about because it is the skin cancer which kills people the most commonly in the US. And that's the ugly duckling rule, where you're looking for changing lesions that bleed and have multiple colors, such as this one. But that's less than 10% of skin cancers, and we're going to be talking about the more common ones today, basal cell and squamous cell carcinoma, and preventing those. So here I'm going to show you a very complicated slide. This is a slide that I've created with the Bill and Melinda Gates Foundation funded Institute of Health Metrics and Evaluation out of the University of Washington. And it shows all of skin disease disability over the lifetime. So this is as big a picture as we can get in dermatology. The y-axis is disability judged in disability adjusted life years. The x-axis is the lifespan in 5-year increments. And you can see that rusty box at the top there. It's getting bigger as we go across. Whoa, sorry, I've got some kind of automatic slideshow on there. So you can see right here, that rusty box is squamous cell carcinoma disability at the end of life. And it's getting bigger as we get older. The light blue box underneath it is melanoma disability. And what's notable is that the squamous cell carcinoma disability is getting bigger than the melanoma disability sort of after age 70 there. So this is a big part of disability from skin diseases. So what chemopreventive agents do we have to work on these? Well, there are sunscreens, and from the work of Adele Green in Australia, we know that sunscreens prevent actinic keratosis and squamous cell carcinoma, but they don't prevent basal cell carcinoma. And if you're a vampire now, you might be looking for very effective high SPF sunscreen around Halloween, so you can come out during the daytime. Another preventive agent that's taken orally that was featured in a New England Journal of Medicine article a few years ago is nicotinamide, and that's had mixed results. It does prevent skin cancer, squamous cell and basal cell carcinoma while you take it, but what was interesting is the more aggressive basal cells went up while you were taking that. So there are mixed results on that. Retinoids are another agent that's commonly used in dermatology, or was very commonly used in dermatology for people who are having lots of skin cancers. And they are effective at high doses, but they induce a lot of toxicity, which limits their the amount we can use them. Topical 5-FU is another agent, and that's the first agent I want to talk about with regard to a cooperative trial study. We utilized a 5% 5-FU study in the VA. It's effective and it's been used since my birth year, 1963, to prevent actinic keratoses. But no prior study had looked at it for cancer prevention. And this study was cooperative trial study 562. It looked at 5-FU plus freezing or cryotherapy versus cryotherapy alone in veterans over the years 2009 to 2013. Down at the bottom, you can see the intervention cream, the molecule, and depiction of freezing. Again, Dr. Marty Weinstock was involved with that. We were a site in this 12 VA site. There was a 5-year study, and Nancy Boyd was my Denver clinic coordinator for that trial. Thank you, Nancy. Now that cream does have this side effect, so you get a pretty good rash when you're using it. And we like to say if you don't get a good rash, you might not get a good result. But that was a double-blind randomized controlled trial of 5-FU twice daily for 28 days. Every 6 months there was follow-up. There were 972 participants at 12 sites. And that showed this result, that topical 5-FU did decrease squamous cell carcinoma 75% in the people who participated that one course of it, but not basal cell carcinoma. So topical 5-FU prevents squamous cell carcinoma of the skin. What do we use now for basal cell carcinoma, which is the most common most common skin cancer? And we're currently investigating or proposing from a grant we got to design a trial, topical imiquimod. Now, topical imiquimod is used to treat squamous cell carcinoma of the skin and basal cell carcinoma. So our question now is, can it be used as a chemopreventive agent that prevents basal cell? And we've proposed the trial number 2019 in the VA cooperative trial to be conducted over the years 2020 or 2021 to 2025. The trial will use this agent, imiquimod. Here's what it looks like, little catch-up packets of the agent. And it will be used on the face once daily for 12 weeks. The mechanism of action is through toll-like receptor 7 agonism, and it induces here's the toll-like receptor 7 that's present in keratinocytes and is also on dendritic cells in the skin. And it triggers a molecular signaling within those cells, which releases pro-inflammatory cytokines, which then goes on to prevent the skin cancers or to treat the skin cancers. We're wondering if it prevents the skin cancers. Our primary endpoints of the study are basal cell carcinoma rates on the face at 1 year and also over 3 years. And the inclusion criteria for the study will be those over 18 years of age, 18 years of age or older who have had a recent basal cell carcinoma on the face, and no AKs, no AK field therapy in the last 2 months or imiquimod on their face in the last year. It's going to be a huge trial like those cooperative trials that tend to skew cancer center recruitment rates. And we're thinking we're going to be recruiting 1,700 patients at 17 VA sites across the nation over the coming 5 years. If we get funded, we did get a score which is fundable, and we are waiting currently for our official funding letter. It's going to be powered for a 40% decrease in basal cell carcinoma over 1 year, assuming a 10% attrition rate, 80% power at a 4% significance rate. So the study design again is a randomized controlled trial of topical imiquimod versus placebo at 17 VAs with nearly 1,700 participants. And that's where we are. We're waiting for our funding letter. We hope it's coming soon. And I want to thank you for paying attention to skin just a little bit today. I thank all my collaborators here across the VAs nationally, as well as my co-investigator, Dr. Marty Weinstock, and my big data, dermatology big data research fellow, clinical research fellow, Torrin Sifson, who's on the call here today and listening to us. So at this point, I'll take any questions anybody might have.
So, wow, first of all, Martin doesn't look that young. I know him. You have
an old picture. Old picture.
I know him for 30 years. That's not fair. So when you say that you will have these BCC patient and you do the trial and looking for 40% decrease, what will be your starting criteria to see a 40% decrease? Because as you may know that I do a lot of keratinocytic skin cancer research in preclinical models, squamous, basal cell, and all that. So it will be something good to know from your perspective that what is the patient population if I want to move ahead with some of my compounds in the clinical trial with you.
Right. So I believe it's a population rate of 40% and not a, let's see, the question again is, let me see if I can rephrase the question. Are you wondering if the 40% for which it's powered decreases based on a actinic keratosis in the patient or in the population?
When you say that in the trial you're looking for 40% decrease in BCC,
yes.
So what you're measuring for a 40% decrease in BCC?
Yeah, so that's 40% decrease at 1 year. So BCC counts at 1 year into the trial. So comparing the placebo group to the treated group.
Okay. I'll follow it up later with you.
Yeah.
We have time. Okay, thank you.
I wanted to add just one question. It's probably more clinically relevant than research relevant maybe, but what, you talked about, what about melanoma prevention? Do we have anything? Is there anything that's being tested right now that's interesting?
Well, I started my career looking at the possibility of using statins as a preventive agent for melanoma, and did not find, rehashing individual patient data from cardiac trials, and it did not find a significant effect for melanoma in particular when you looked at all trials as opposed to those which had reported an effect. I think sunscreens and sun avoidance are still the mainstay for melanoma protection, and we don't have another agent that's currently real promising. There are NSAIDs, which do have a small effect in preventing melanomas if used a lot, but we're still looking for a chemopreventive agent in the melanoma realm.
All right, well, thank you very much.
But what will be the patient pop? This is the same thing. See, the problem in chemoprevention research, including skin cancer chemoprevention research, is the fact that what is the starting point of patient population which you say that can be used, and then you say there's a chemoprevention down the road. So if you want to talk about melanoma, I mean, do you start with the nevi, or where do you start and where do you end up? I mean, like melanoma is deadly cancer anyway. We cannot just mess around with that.
Mm-hmm. I agree. glad we have some people interested in skin. Sometimes skin gets the short end of the stick.
I've been doing 35 years. I mean, we never had a chance to talk to each other, but that's the first thing I started still doing it.
And I do want to put a call out to our Northwestern Cancer Prevention Consortium, which I've been a member of the Cancer Center for many years, and I wasn't aware of the consortium in skin cancer prevention until this year.
It's not skin cancer; it's all cancer, and
I mean all cancer.
York is in that group, and I'm in that group, and we know SEMA fairly well. York has got money a couple of times from them for clinical trial, and we are hoping that your project is taken in a very positive manner, and you get money from this. It's like NCI money. So, I mean, this cancer center is like a broker, and we are the reviewer to pick some grants, and then those grants are forwarded to NCI. That this is what we think should be funded, and most of the time we do get that money. So going from there to NCI is a good news. Let's put it this way.
Yeah, and I apologize for my dog who's going crazy in my yard. I have to go see what's going on.
Somebody's going crazy somewhere.
All right, well, thank you very much. We'll go ahead. Originally, we'd planned to put in a break here and encourage anyone that needs a break to go ahead and take it like you couldn't anyway. But we're going to go ahead and motor through to our next presentations. But before we make this full transition, I want to introduce the idea that that metabolism in cancer is the second cross-cutting section that we focused on, and is clearly a strong interest and a strength of our cancer center. And I want to introduce Dr. Paul McLean, who leads the center here, and which has been recently refunded and has such a strong trajectory. And I'd like to turn it over to him to just say a couple of words about the footprint that NORC has in cancer prevention and control, and how they might be willing to partner on some interesting work and physical activity, obesity, and other things related to cancer risk and survivorship. So, Paul.
Yeah, thanks, Jamie. I'll be brief. What Jamie's referring to is the Colorado Nutrition Obesity Research Center. And so they've been called NORCs. It's kind of a weird name, but it's caught on. It's a P30 grant that's funded through NIDDK. And we're charged to support nutrition and obesity research on campus. And because there's so many cross-cutting things between nutrition and cancer, and how obesity affects the incidence, the risk and incidence and outcomes from a number of different kinds of cancers, about 10% of our research base is NCI funded. And so we have an interest in collaborating with the Cancer Center and welcome cancer centers to apply for our pilot funding program, which usually gets announced in March. We have 3 cores that help people do nutrition obesity research at the basic, preclinical, and clinical level. Particularly relevant to cancer prevention control is we provide weight loss interventions over at the Anschutz Health and Wellness Center. So we're really interested in partnering, and we have a partnering pilot program it's under review right now. But if you have interest in learning more about the NORC, you can go to cunorc.org. And there you can get in touch with us and become part of our community as well. So I'll leave it there unless you have any questions.
Well, Paul, I appreciate that. And I know that the Cancer Center is really excited about the collaborative grant mechanism and as well as this mini symposium that was held. And this is just a really important part of our portfolio, and we want to make sure all of our physical activity and obesity and nutrition researchers in cancer prevention control are really taking advantage and well represented. So thank you for saying a few words. And speaking about that, our next speaker is Dr. Heather Leach, who comes to us from up a little bit further north, I believe, kind of highlighting the fact that while Colorado State will not be a consortium member in our next application, they are very much a part of our cancer center, and the same way with our colleagues in Boulder, and that they have a very strong scientific footprint, particularly in cancer prevention control, and Heather's work in physical activity and survivorship interventions that integrate a psychosocial component as well is really an important piece of our work. And I really appreciate your willingness, Heather, to present and share some updates with us.
Yeah, thanks, Jamie. Are we ready for me to go ahead and share my screen?
Sorry, it had already gone to mute, but go ahead and share your screen and you're all up and ready to go.
All right.
You might turn up your volume just a little bit.
Sure, is that better? Can you guys hear me better now?
So it's still a little bit light for me, but I can hear. So just go ahead.
Okay. All right. So are you guys seeing my large slides, or are you seeing like my notes slides? Large slides are good. Cool. All right, so I am going to try to stick to my time. I have 2 goals: stick to my time and my dogs to not bark for the next 15 minutes. So I don't have high hopes, but here we go. So I was going to talk to you guys a little bit about, very brief background on sort of where we're at in terms of evidence, research, and physical activity for cancer survivorship, and then talk briefly about just a couple studies we have going on in my lab where we are looking at this idea of social support as the exercise group in some of our interventions as a way to enhance physical activity behavior change. All right, so in terms of the current literature, we right now have a lot of evidence when it comes to physical activity and cancer survivors. This field really exploded over the last, I would say, decades. You can see here almost doubling from 2009-ish to 2019. So just to put in perspective, every year for the last 5 years, there were over 800 papers published per year. So more than 2 papers per day on this topic of physical activity for cancer survivorship, or also referred to as exercise oncology. So currently we have multiple systematic reviews, meta-analyses, reviews of reviews that have demonstrated the effectiveness of physical activity or exercise for improving health outcomes in cancer survivors. Last year, the second consensus statement and physical activity guidelines for cancer survivors were released. And really, I just want to direct your attention in this busy slide to sort of the broad conclusion that they came to. This was the American College of Sports Medicine. The conclusion was that we have at this point strong evidence for the effects of aerobic and resistance exercise for several health outcomes among cancer survivors, including fatigue, quality of life, physical function, anxiety, depression, and for resistance training, lymphedema. We also have accumulating observational evidence that supports the effects of physical activity for reducing cancer-related mortality, or conversely improving survival among cancer survivors. So this particular study, for example, they totaled, oh gosh, it was a bunch of studies, but it was more than 4 million participants. So this was a huge review and meta-analysis. And they found that people who were achieving approximately what we think of as the guideline, physical activity guidelines for adults, so about 150 minutes of moderate intensity physical activity, so right there at the red line, which equates to about 10 net hours of physical activity per week, they saw about a 25% lower risk of cancer-related mortality. So a more recent systematic review, this was published just last year. So they only had enough studies to draw conclusions for breast, colorectal, and prostate cancer. But what they found, they were comparing individuals who reported the highest versus the lowest category of physical activity. And they found for that these three cancer types, so for post-diagnosis physical activity, they found somewhere in the realm of about a 30% lower risk of cancer-specific mortality, and somewhere between 38 and 45% lower risk for death from any cause. So, yay, exercise is great. I think, you know, at this point that is pretty well established, but the tricky part is getting people to actually do it. And this is not surprising given the additional barriers to physical activity that many cancer survivors face related to psychosocial factors, physical function barriers. So the number of cancer survivors engaging in physical activity levels that are enough or adequate to elicit all of those benefits is really quite low. So these three are the most recent, at least over the last couple of years, studies that have looked at how active cancer survivors are. And I think the bottom one there is, you know, everyone always asks, well, is this self-report or device-based? So that last one there, 8% meeting physical activity recommendations, was the last one that looked at objectively measured physical activity. So overall, as with many adults in the US, cancer survivors might need some help becoming more active or getting back to their activity levels that they were pre-diagnosis. So what do we know works in terms of helping survivors increase their physical activity? And again, lots of evidence in this area as well. Multiple systematic reviews, Cochrane reviews suggest that the things that work really well include supervision and instruction. So basically incorporating an element of how to perform the behavior. Theory-based behavior change strategies. So some standouts are goal setting, setting graded tasks, and self-monitoring. And the last one was social support and contact with other participants in the intervention or program. And this is the area that I'll kind of focus on for the rest of this talk. So we have also, you know, a lot of anecdotal. So anyone who's worked in a group setting with this population with cancer survivors, especially in an exercise setting, I think can attest to the comments that they get from their participants where they loved coming to see their friends and they made friends and they loved that sense of camaraderie. So those anecdotal bits that we probably all have is also supported by the qualitative literature, suggesting that there's something about exercise that people also love in addition to being with other survivors. So it's this combination of we're not just sitting there talking about our cancer, but we're also doing something that is very energizing and motivating. So sort of this combination can be really powerful. So as a quantitative researcher, I was like, this is awesome, but how do we quantify that? And so I was really interested in some of the group dynamics literature that came out of sort of the early 90s into the 2000s, led by Karen Spink and Paul Estabrooks, where they were looking at how we can systematically incorporate strategies that target sort of this sense of a team, the sense of group cohesion, and is that better than just throwing people in an exercise class or doing personal training or other kinds of things. And the general consensus from this literature is yes. So what we were interested in doing is testing this hypothesis in a cancer survivor population. So a couple years ago, we did a pilot study in my lab up at CSU where we compared the effects of a group dynamics-based exercise intervention to a personal training intervention in a sample of breast cancer survivors. And so we looked at various outcomes, most notably physical fitness, quality of life, and physical activity, and both right after the intervention and 3 months following. And so what we found, so not surprising, and this is our physical activity outcome here, not surprising, both groups increased their activity. We were doing a supervised exercise intervention, so of course they were more active. But we noticed the trends for the group-based arm tended to maintain their activity levels a little bit more so than the personal training arm. And you'll obviously see huge variability in our standard deviations, these are confidence intervals. And we looked at it in a different way. We looked at the percent of participants meeting physical activity guidelines. Again, 3 months after the intervention, we saw over 90% in the group-based arm compared to closer to 50% in that personal training arm. So we were able to take this pilot data. So again, this is a small sample, lots of variability. So we were able to take this pilot data and parlay that into an ACS Career Development Award with the plans to expand this notion of comparing group-based exercise to personal training for quality of life, physical functioning, and long-term physical activity. And we were planned to test this in colorectal cancer survivors. So we had just started a multi-site randomized control trial. We started enrolling in January, both at Anschutz and at CSU. So January 2020. And then COVID happened. So we had government shutdowns. We had non-critical research suspended at both sites. So I spent the majority of early 2020 doing this. Thinking, what the heck are we going to do? We were forced to withdraw all of our participants, right? Research was shut down. So everyone we enrolled was forced to withdraw. And so I hope a lot of you are sympathizing with this meme as well. So once we sort of got over the, oh my gosh, our entire research program was shut down for months, what can we do, right? So once we started putting into place protocols, COVID safety protocols, for this particular study, there was a lot of questions. Given the age and health status of our participants, is it safe to even bring them to campus? The nature of our study in terms of exercising in groups and our hypothesis that social connectedness matters. How can we do this while still social distancing? So lots of questions and concerns. So the next thing we thought about was, well, can we do this virtually? Can we replicate what we were doing face-to-face with our groups of participants? Can we do this online? Can we have people exercise as a team? Can we do our guided behavior change education and discussion sessions? Can we give them live, real-time supervised aerobic and resistance exercise on Zoom? So we had a lot of these questions, and meanwhile, the Cancer Center had a grant come out, a pilot grant. So we thought, why not write this and try to test this as well? So really, we're interested in whether this type of intervention delivered virtually, is this a way that we can help cancer survivors not only increase their activity and also maintain that connection with other participants? So I'll kind of skip to where we're at right now. So I say we are pilot testing this for the Cancer Center grant. We also just got our COMERB approval to transition our ACS study to this modality, but we are also, I like to call it beta testing this procedure in our outreach program that we run up at CSU. So I will give you guys just a little snippet of what something like this looks like. So you can see our participants here all in their group t-shirts, which is one of our favorite things. We have 2 instructors. So we have one who demonstrates the exercises and another who is really focused on participant form modifications. So you can see Matt on the headphones there watching our participants, and he's able to pull someone into a break room and have a chat with them if they need to, and then they can pop back into the group exercise. So you can see our group warming up here. And you know, we've designed a lot of our workouts with minimal equipment. We do provide them with some resistance bands, but really some minimal equipment needed. So I think you guys get the point there. So that's kind of where we're at. We're beta testing. We just got IRB approval to do our pilot study with this for the Cancer Center Innovation Grant. So we are up and rolling, and I'm no longer sitting in my living room looking at pretend flame, my research program go up in flames anymore. So we're super excited about this, and I will cut it there and I'm happy to answer any questions.
Heather, thanks for that. I harken back to my clinical days when I did something similar with a colleague who was a psychologist and a exercise scientist both. We did a combined group intervention that combined some supportive counseling with physical activity intervention. And we found, you know, everybody signed up for the physical activity, but they stayed for the social support. You know, actually, it was like a 12-week intervention. I don't think anybody continued exercising afterwards, but they continued to meet as a group for lunch once every other week or something like that. So it was really interesting, and I began to see, as a psychologist, see physical activity interventions as a vector, you know, not just for physical activity, but exactly like you're talking about, for the social support and the emotional support that folks could provide, that they wouldn't enter the door if it was only emotional support, because that's too big of a stigma, too big of a barrier. But if you were able to combine it, people really gravitated to that. And so there really is a question, well, how's been accrual? How's been accrual?
Yeah, so for our pilot that we did with breast cancer survivors up in Fort Collins, accrual was a breeze, I will say, which you hardly ever hear. We recruited really quickly, no issues, and it was great. And then when we got the ACS grant to transition to colorectal cancer survivors, you know, part of my career development was working with a new population. So I had a bit of a rude awakening to the challenges in working with non-breast cancer survivors, where our recruitment was very slow. So we had multiple amendments to expand our inclusion criteria. And now we're hoping that the virtual delivery will actually help us in the sense that we can expand our reach beyond people who are in driving distance of either CSU or the wellness center. So yeah, accrual has been mixed. In the 2 studies I've done so far in our outreach program for Fit Cancer, again, it's very dependent on this kind of like semester. We have had upwards of 15 to 20 in a couple cohorts, and then as low as 3 in a couple cohorts. So I think, you know, we're still working on, you know, getting on the front of our clinicians' minds in our cancer rehab up in Fort Collins, and coordinators and things like that, to get this to be part of what they are referring people to.
Very good stuff. And you're seeing some comments in chat that you might want to respond to as well, and some very good points there.
Yeah, the question is socioeconomic sense a determinant of participation in this virtual program. That is definitely to be determined. We're hoping, you know, one of the things with our pilot is trying to see, you know, when we're accruing, how many people do we have that aren't eligible or can't participate because they don't have reliable internet or they don't have access to a smartphone or computer. And if that's the case, maybe that's something we then write into grants or programs that we can provide these things for people. But based on what I've read, I don't think it'll be a major problem. But again, I can't yet speak from experience. And with in terms of equipment, we're providing all the equipment for people, as well as, you know, obviously no cost for participating in the study. So hopefully not a huge barrier, because again, one of the benefits of the virtual delivery is the increased reach, where we can get at these more disparate populations in rural communities. So hopefully we do not run into those issues.
So in my one last sarcastic kind of joke is that if you want to feel better about your colorectal cancer accrual, open up a lung cancer trial. So, okay. Thank you very much, Heather. Really exciting work, and best wishes. And please let us know how we can continue to support things. And I was thinking that you know, the physical activity, supporting the physical activity interventions or accrual could be something that eventually, as the PHSR grows, to adopt and facilitate accrual, that could be in clinics and helping people navigate your way as a possibility. So.
Absolutely. And I think, Jamie, I'll be in touch with you with this innovation grant, because I think we have budgeted for Cancer Center shared resources, and that would be extremely helpful for us.
Terrific. Thanks. Next, we're going to turn it over to Dr. Raj. Raj, you know, is the old man of the group. Senior experience, has been terrific to help advise me and to prod me along in terms of preparing our Cancer Center Support Grant application. Obviously, an internationally recognized expert in chemo prevention, making some really strong discoveries over his career and translating those into patients at this point. And so I'll turn it over to Raj, and we look forward to hearing your comments.
Thank you very much, Amy. I am old in the program, both age-wise and my time-wise, that I've been there for several years. So thanks for reminding me that, Amy. What I'm going to do is talk about some of the lab research after hearing such important aspect of you know, clinical trial from Bob and a lot of service research and things like that. So what you see over here, I hope you can see my alrighty. So yeah, so this is let's do it this way. I think I'm fine here also. So the topic Jamie picked for me was diet, nutrition, chemo prevention, and I just want to bring the blend of cancer cell metabolism, which is the cross-cutting theme of this particular session. And I want to talk about the work we have been doing with a fruit or vegetable called bitter melon. As you see, these are the fruit of bitter melon, and we have been working on them for a very long time. So let's talk about diet, nutrition, and chemo prevention. Some of you may have seen this slide several times, and some of you may not have seen this slide. So why this slide is important? Because it pretty much covers most of the aspects of chemo prevention research. We have heard about diet and nutrition. As you can see over here, there's a man jogging forever for his cancer chemo prevention, including prostate cancer. This lady is just doing exercise, eating healthy. And so many healthy diet come from fruits and vegetable. Obviously, there is a bitter melon. And in most recent time, a lot of research has moved from all these natural ways of remain healthy and preventing the diseases, including cancer. There's a lot of effort on supplements also, and they have pure compound, they have mixtures, and they have not. And then more recently, we have targeted drugs for different pathways, which are being studied for the chemo prevention. So That is what it's all about related to chemoprevention research. Now, every single person has cells in the body which are the normal cell, but with the DNA damage become the abnormal cells, which grow into the early stages of tumors and become the clinical cancer as a function of age and time and depending on the damage and what else is feeding that damage to make the tumor grow and things like that. Uh, just like the normal cell, we also have the normal stem cells, and they are more, dangerous when they become cancer. They are very hard to control and kill by the agents we have for the chemotherapy and things like that. So a lot of effort over the years has also uh, moved to the modality where we try to target both cancer cells, which are over here, and cancer stem cells. They are together important to control. So why bitter melon? Bitter melon is a vegetable, as I said, and it's consumed as a vegetable, cooked and raw. And the juice is used in Asia, Africa, and parts of the Caribbean. You believe me or not, pretty much every week I get vegetables to eat in my house made of bitter melon. So this is common in Indians as well. Uh, and it has known health effects in terms of reducing the type 2 diabetes in some controlled clinical trial and so forth. So um, it has the history of human use as vegetable and as a drug or complementary drug. So that potential is there, and the idea is how we can translate it to the cancer research. So not only my lab, several labs have been working on bitter melon juice, and it has shown activity in different cancers and a lot of good activity. And we have been working on the pancreatic cancer with bitter melon almost for 6, 7 years now. And we take the bitter melon, we juice it down like a regular juicer we use in the kitchen, and we get the juice and we lyophilize it and make it into the powder. And this powder is the one which is used in most of the studies we and others do something like that. Why pancreatic cancer we're talking? So pancreatic cancer is something, just look at the 2018 numbers. Estimated incidence almost 55,000, look at the death, 44,000. So almost 80% of the people who diagnosed that particular died. Most of the cancer, if you see, those numbers are not like that. That once a patient diagnosed with the prostate cancer, look at the 5-year survival, 3 to 5%. So really deadly cancer, and uh, this cancer has got less attention in the past and getting the most attention in the present time because of these numbers as you see over here. So what do we do in the lab? We take the agent, this material from here, and we take different human cancer cells. So here we took 4 different kind of human cancer cells, pancreatic cancer cells obviously, and treated them with the bitter melon juice and asked the question, it has any effect or not. So when you see over here, 0 is the control cells, 3 different concentration of 2, 4, 2, 3, and 4%, 5% bitter melon juice and things like that. And you see a decrease in the OD, and that represents that the agent is working in terms of inhibiting the growth of these cancer cells and making them die. And the effect was same in pretty much all the 4 cell lines. We also look for the kind of death, and it is called apoptotic death. And 2 different cell lines we use, and we see a strong increase in the number, showing that it causes apoptotic cell death, and that's a mechanism most of the agents do to make the cell die. This is another common way of doing the lab research, where you see that what agent is doing to the cells, and we have so many different proteins which we measure by a technique called Western blot. And here, what I'm trying to show you is the data showing that with the treatment with bitter juice, these bands change all over. And bottom line of all that thing is that it is changing the molecules which have a role in making the cell die by apoptosis. It matches with the data which we have over here. We did another experiment related to the AMPK, the molecule related to cancer cell metabolism. And when it increases, it means that compound has effect in modulating the metabolism of the cancer cell. And indeed, bitter melon juice was very effective in reducing that molecule. But because of the time, I cannot just go over all the data, but bottom line is that one mechanism of its effect is that it causes the increase in one of the metabolic molecule called AMPK, and that causes the apoptotic death of the pancreatic cancer cells. That's the effect of bitter melon juice. So moving from there, we ask the question that overall what it does to the metabolome of the pancreatic cancer cells. So this is a petri dish where we grow the cells and treat them bitter melon juice, and we collected the uh, soup and the lysate and did some kind of um, work with the help of my good friend Natalie Sarkova, who is the director of the imaging program at our cancer center. And there's a lot of fancy little details about how she does all those studies. But the bottom line of all this stuff is, as you see this open bar, you see increase in lactate and glucose and things like that, showing that when we treat these pancreatic cancer cells, different cells, you see two of them here, it does do things which make a change in the cancer cell metabolism. And that metabolism change was also associated with, as you see over here, um, the two molecules I'm showing. One is the GLUT4, which is involved as a transporter of glucose. Another molecule known as MCT4, which is involved as the transporter of lactate in the cell. And compared to control, which is over here, different time point for control cells. When we treat with bitter melon juice, you see a big decrease in these molecules over here and over here, suggesting that that is the mechanism how it controls the metabolites or metabolome of the cancer cells in pancreatic cancer. Natalie and we also did a lot of experiment and found that this is another technique used by Natalie in her imaging resources called MRI and FDG PET. Bottom line of this whole thing is, as you see over here, this is the tumor in control. Tumor is shrinking when you treat with bitter melon juice. More so you can see when you see these big uh, lining here of this is the tumor control, and see how small it is in the bitter melon treated mice. Same kind of experiment we did, and the overall the curves you see here, this is the curve in the control mice where you see the growth of the tumor, pancreatic tumor, and these are the curve for the mice in two different groups treated with bitter with very strong effect of the agent over here, and some of the markers to show that how these changes are happening. The important point was whatever I showed you in the cells, same GLUT4 and CT4, the changes were exactly same as you see quantitatively and qualitatively here in terms of green staining, this is control and keep going down, and red staining for other molecule keep going down. And these are the numbers, this is the control, and this is the treatment for both these molecules. So whatever we see in the petri dish in the lab, same data we find in the mice, showing the effect of bitter melon juice was kind of driven by its effect on uh, modulating the metabolome and the transporter of metabolites in the pancreatic cancer cells. So just to conclude, we found that Vitamin juice alters pancreatic cancer cell metabolome by targeting lactate and glycolytic pathway, and it decreases the glucose uptake by intracellular lactate accumulation. Transporters were decreased, and that's one of the mechanism. And whatever we found in these cells, also see in the mice experiments. So what we're doing, we're trying to further define the mechanism of nutrient stress and metabolic flux, also targeting mitochondrial ATP in these studies, focusing also on the AMPK, which is one of the major metabolic switch in cancer cells. And we're doing a lot of animal experiment to see the chemopreventive activity and seeing if BMJ also modulate the gut microbiome, which has a role in some of the efficacy we found and we just studying right now. So here are a lot of people in the lab who have been working over the years on chemoprevention work. First one is obviously the boss here, my wife, Dr. Chapla Agarwal. The people who work on this project, especially as Dr. Komal Rana recently moved to South Dakota State University as associate professor. Other work is done by this graduate student. She has graduated working for Johnson & Johnson. And there's one more person I'm trying to figure out who has been instrumental in doing a lot of that work. Cindy was another graduate student who has done a lot of work in this area. And there's RO1 from NCI, which support a lot of this work. And I'll stop here.
Thanks, Raj. I mean, really nice story to see how things have progressed, and this is one of the agents that's now in trial?
Yes. So because of time, I just kept it as short as I could. So this work has moved to the patient-derived xenograft, we call it PDX model. And the most important finding there is in those studies where gemcitabine eventually has resistance to treatment, it reverses that resistance in the studies. And based on all that data, we are moving to phase 1 clinical trial and funded by Cancer Center Wings of Hope and our School of Pharmacy funding. And we have clinical collaborator, teamwork, and pharmacy collaborator, and myself. So this is a good example of how lab research can go all the way to the clinical trial and beyond, and that's where we are.
It's a really important story, obviously, for us and for your lab. It's great stuff. Raj, there's a couple of questions in the chat that I'm going to ask if you could take a look at and see if you can respond to. But I want to transition, knowing that we're already over time, and appreciate everyone being able to stick with us this long. And of course, if you have to go, you have to go, but that's no problem. I'm going to throw up just one essentially last slide for us, because we did have a small section originally in the agenda for feedback, comments, questions, and I had just a couple of things I wanted to show folks to kind of wrap it.
Very quickly, Jamie. So the question about pancreatic cancer grown in high and low glucose medium, we have not manipulated medium that way, but when with the metabolome work, obviously we use C13 glucose, so that was supplemented for that study. Body weight is not affected in any of the animal experiment all the time we have done, including most recent experiment just completed last week. Body weight is not something which changes. So obviously it's not toxic and things like that. Spontaneous physical activity must change when they are. I don't think so. There's a spontaneous physical activity change in mice when we treat with betamelon juice. But we did not specifically look for that particular parameter, but I don't think we have any behavioral change in the mice with the treatment.
All right, thanks, Raj. In terms of transitioning to the wrap up, just want to let folks know if you have any questions or comments, you're always, or really if there are ways that the Cancer Prevention Control Program could support your research. That's why we're here, to be your advocates, and whether it's helping secure resources or break down barriers or navigate through any of the other complexities and regulatory systems. You know, we've tackled a few of them that we've brought down in the last year or so, but I know that there's other ones that are out there. And so I'll ask for any comments or feedback about that in a minute. But I know you were all extremely excited to receive the invitation to join another listserv so you could get more email. I know you know the excitement was probably overwhelming, but I did create a listserv, and we will constrain ourselves to things that we really do believe will promote careers. Our major focus of those distributions will be to share notices of and grant opportunities that are widely relevant to cancer prevention and control. If they're relevant to only a narrow band, we'll try to be more selective in sending those things directly to folks. But we also, you know, want to create a sense of camaraderie and networking and collaboration. So if you would like to post a success story, please do so. If you got grant funding, if you'd rather have me post it, please forward it to me and I will post it. These can be publications or other successes, community outreach efforts that you're proud of, and things that we want to be able to celebrate. And so anyone can post that's on this. We're slowly building the listserv to include. Right now we have it set up so that it's monitored. Everything that's posted has to be approved by Raj before it can be posted. So we'll try to, but we really will try to keep this to a limited set to not overboard you with additional email. I wanted to highlight one particular opportunity that has been somewhat referenced already, that the NCI is genuinely interested in a trajectory supporting a broader portfolio of research that addresses the rural cancer prevention and control burden. We've been fortunate to possibly get a fairly substantial carve out of that funding, but there is a new one. I've sent this around a little bit to a few folks who might have a footprint, but the interesting piece about this one is it's not early detection, it's not survivorship, it is all cancer prevention, modifiable risk factors for cancer in rural populations. And so I've heard of a couple of folks that are interested in this. We are not constrained in this competition anyway. We can submit 5 grants if we wanted to, if we had that motivation. So there's no constraints there. However, I do feel that we help each other out if we're not submitting overlapping projects that are proposing to do the same thing in the same population and things like that. That, in my experience, that does not go over that well at study section. People have questions. So we would, if you're planning to respond to this, well, it's more than an RFA because it has multiple submission deadlines. So if you submit once, you'll have a second chance at the apple with some feedback. But if you are planning to respond to this, please let us know so we can help navigate that. And the goal is not to constrain anyone, but to put all of our applications in the best light possible. And last thing it goes on is ideas for the future. We obviously want to grow and expand and support your research. I'm still new and not afraid of asking questions and asking for resources to help our program. Haven't been slapped down that many times yet. So if there are things that would generally transform your research that we can help with, please let us know and how best we can do that. And finally, thank you so much for allocating 3 hours of your Zoom time to the retreat today. It's greatly appreciated. Thank all the speakers for preparing and sharing your research with us, and hope to be able to support more of that. I will now stop talking and let Raj either say a few words, or if people have questions and comments or just want to post them in chat, that's okay too.
Well, I just want to echo just what you said. Jamie, this was very productive retreat after what I have gone through in last 6+ months for all of us, just working the way we are working. So this mechanism has been helpful, at least to see each other and hear each other in terms of what's going on. And I already note down some points for me to follow with some of you about where I can get help for my work. And I'm sure almost all of you have your own points to follow with other people on the retreat, presenting or listening. If there's anything you feel that a program can do for you, don't hesitate even for a minute. I mean, at least one thing Jamie is very good about is replying to the emails, if nothing else. So just shoot him, copy me, and I'll make sure that we get back to you on your questions. We have opportunities for funding also. And whenever that comes, we make sure all the members get that announcement. Any collaboration you think where we could be of help to just connect 2 of you or 3 of you, 4 of you, we can do that also. So there are several different ways to have more interaction among all our members and also other members in the cancer center and beyond. So we look forward to all those opportunities. And thank you again for spending time with us today.
Any comments, questions, concerns? Voice them here or voice them on email. It's just been delightful to be here, and so thrilled, and thank you. And don't forget about the magic show. We'll if and any final words, Stacy, about the magic show?
I'm excited about it because I don't know how you can do a magic show, but I'm one of the participants, so I have a little sealed bag that I have to open during the show. So I think it's going to be really interesting, if nothing else.
Absolutely, yeah.
Creativity. It's stimulating some creativity. Best of luck with your research, and hope you have a wonderful weekend. And thanks for your time today. Take care.
Thanks, everybody. Bye now. Stay safe.
Oh, and thanks, Ellen, for all the work and setting things up,
yes,
organizing,
yes,
and making it all happen. We greatly appreciate it.
Yes.
Ellen, kudos.
Indeed.
Thank you, everyone.
Yes.
Thanks, Ellen.
Thanks.
Bye, everybody.
Bye-bye.